we will have Dr. Nafisa Shakir Bata, the Senior Consultant Radiologist from Perami18Sept Hospital, New Delhi, India. Dr. Nafisa will give lecture of athletic pubalgia, spectrum of sports groin. Dr. Nafisa, the time is yours. Pubalgia, spectrum of sports groin. Dr. Nafisa, the time is yours.
Good morning, everyone. I'm Nafisa Bhatta. I will be speaking in the next 20 minutes about imaging of the sports groin. I work at Safdarjung Hospital Sports Injury Center. This was inaugurated at the time of the Commonwealth in India in 2010. So let's look at the anatomy. The deepest layer of the abdominal musculature is the transversus abdominis. Through the arcuate line passes the rectus abdominis strap muscles. These show inscriptions fondly called the six-pack. And if you see that these recti do not have a posterior sheath in their distal thirds, and that is why it has a propensity to have posterior wall weakness. On top of the rectus abdominis is the tendons of the internal and external oblique, which contribute to the anterior rectus sheath. We have a linea alba. Paracentrally, we have a linea semilunaris. The reflections of the inguinal ligament, the superficial inguinal ring as seen here. Most sports groin pains originate in this region. The pubic symphysis, housing the fibrocartilaginous disc, the aponeurotic prepubic plate, which houses the insertion of the rectus abdominis superiorly and the adductor longus inferiorly. And then we have also the inguinal ligament falciform reflection. So the pubic tubercle gets attachments from the superficial inguinal ring, the rectus abdominis superiorly, the inguinal ligament laterally, the adductor longus inferiorly, and the pubic symphysis medially. Sometimes the pain can be neuropathic. Usually, neuropathic pain in this region is due to genitofemoral or ilioinguinal nerve involvement. Either this can be a frictional rub through the rapidly contracting musculature, or because there is scar tissue or fibrous tissue through which these nerves are entrapped. So whatever happens in this box, right? So pubic tubercle, pubic symphysis, the paraphyseal bone should be looked for marrow edema, the adductor longus, and this diagram lacks the rectus abdominis and the prepubic plate, which really sits anterior to all of this and is continuous with the origin of the adductor longus and the insertion of the rectus abdominis. What's important to remember is there is no hernia. Even though this was earlier known as a sports hernia, there's really no hernia. There's no defect, and there is nothing protruding through a sac. There is weakness of the posterior musculature, but that we'll see later. So who gets this? Any athlete that requires rapid changes of direction, repetitive side-to-side ambulation, frequent forceful twisting of the trunk, and kicking. Soccer, ice hockey, basketball, baseball, football, very common. And in India, hockey, tennis, and cricket is quite common. Apart from that, track and field athletes are also disposed to this condition. So the rectus abdominis tends to pull the pubic symphysis upwards, whereas the adductor longus tends to pull the pubic symphysis inferiorly and outwards. So there is a balance of force required at the pubic ring so as to not get injuries of the pubic symphysis. Now, there can be cross counterbalancing as well. So one adductor longus could be balanced by the other rectus abdominis. So basically, these two strap muscles and these two adductors, the forces along both their vectors have to equalize and counteract, and only then the pelvis is in a stable condition. Any sort of instability that occurs can lend to sports injuries of the groin. Here is the rectus abdominis, and this diagram rightly shows that in spite of the fact that its fibers do attach to the pubic tubercle, you also have fibers continuous into the prepubic plate, which go on to originate the adductor longus. So this is how it happens. Athlete would go to drive a forceful kick while the pelvis was already in imbalance, where the hip was already flexed, and he would immediately get groin pain. And in this case, he had a adductor tear. There is a lot of heterogeneous taxonomy around the sports groin. There are multiple terminologies that have been used, and I don't think any of them is fitting perfectly. The Doha Agreement said that you should try and club all these patients with groin pain into four main subcategories. Pubic related pain, which would be central. We can have adductor related pain, which will be in the region inferolateral to the pubic bone and will increase on resistive adductor testing. We can have inguinal related pain in this region, which increases on Valsalva, maneuver, cough, sneeze, etc. Or you can have hip and iliopsoas related pain, in which case the pain would increase on hip flexion or Fader or Faber tests. So there's a laundry list of conditions that can mimic a sports groin, but usually the history is compelling and you know what you're going to be expecting. On the MR, a good thing to do is always look at the rectus abdominis, and this is where I personally start. I want to look for symmetry. I want to look at the medial and lateral heads. I also want to look at the inguinal canal, its anterior wall and its posterior wall, and their symmetry. Going down, we'll see the prepubic plate, which is firmly applied to the pubic symphysis. And caudal to that is the takeoff of the adductor longus. And the fleshy muscle that you see behind the adductor longus is the adductor brevis, and the one lateral to it is the pectineus. When you look at it in a sagittal view, the adductor longus takeoff looks as this dark triangular attachment to the pubic bone, and anything away from it is abnormal. So look for tendinosis, look for calcifications, look for tears, either partial or complete. All of this shows that there is some adductor tendinopathy. The prepubic plate can be sometimes well seen on a good corneal section. Here you'll see the pubic plate. You can also see the medial and lateral heads of the rectus abdominis attaching, and you would be able to diagnose the condition. So what do we see in a sports groin? We expect to see delaminations of the pubic plate. So this aponeurotic prepubic plate can tear, in which case we call it a delamination. These delaminations can be simple tears or they can be complex, in which case they can extend inferiorly or laterally, like in this case. So what's happening? What is a secondary cleft? Now, this is a term that is quite often used with sports groin. The primary cleft is fluid collection within the pubic capsule because of degeneration, and this fluid is not seen in a younger individual. It's okay to see it in a 40, 50-year-old or 60-year-old individual. And some authors who injected into the pubic symphysis realized that the radio contrast material leaked into the short adductors. So the theory is that this is a continuous structure, and this fluid can leak due to a tear of the pubic capsule into the short adductors, and that is what we call the secondary cleft. Now, secondary clefts can either run superiorly, or they can go laterally, or they can go inferiorly or posteriorly. Usually they run posterior-inferiorly. So this is a case where you can see that there are some corrugations in the pubic margin that's abnormal. And you'll see in this case that there is a secondary cleft running from the pubic capsule posteriorly and inferiorly into the takeoff of the short adductors. I normally do not do x-rays for a painful groin, but many a times I find that patients come to me with an x-ray. Like in this case, if you look at this case right away, you can see the sclerosis, bony irregularity, and you see how the pubic bones, in spite of a central x-ray, they are off center. So this shows that this patient has macro instability. There's also some calcific tendinitis and microavulsions that have occurred. This patient has an imbalanced pubic ring. He also had some apophysitis involving the sartorius at the anterior superior iliac spine. This is a 21-year-old footballer, and you'll see in this patient that there is chronic ischial apophysitis, and again, there is macro instability at the pubic symphysis, sclerosis, and the off center. In this patient, in spite of the fact that there was no macro instability, the fact that there is sclerosis and irregularity of the parasymphyseal bony margins lends evidence to the fact that this patient has a chronic sports groin. They may or may not always be symptomatic. Ultrasound is good for dynamic scanning. It is great for ultrasound guided injections. It's good even for follow ups. In this case, you can see the adductor longus that has torn off the prepubic plate. You can even diagnose tendinosis or enlargement of the adductor longus. And you may be able to diagnose the weakness of the posterior musculature at this level on a Valsalva maneuver. But for all practical purposes, MRI is the modality of choice to image a sports groin. So, what are the things that we look at in an MRI? First of all, we look at the pubic symphysis, we look at degenerative changes of the bone, you look for fluid inside the pubic cartilage, you look at thickening of the pubic capsule, then you look at the adductor muscle insertion, right and left. Is it symmetrical? Is there any atrophy? Is there any tear? Is there any fluid? Is there any tendinosis? And we look at pubic marrow or osteitis pubis as it is called. And we also look at clefts, so secondary clefts. And these clefts should be described correctly in terms of their size and extension, whether they're simple or complex. So let's look at a few cases. This is a patient, coronal T1. You see how you can see the medial and lateral heads of the rectus abdominis on the left side well, but on the right side, clearly there is reduction of the lateral head of the rectus abdominis. A good idea is also to look at the linea semilunaris and the linea alba. And in this case here, we can see that the prepubic plates shows good dark signal. When you look at it in axial, you see that the rectus abdominis is definitely asymmetrical. So you're expecting some problems on the right side. And here it is, we have a secondary cleft or a tear that is extending into the adductor longus. This is a patient who had a small cleft on the left side. This is a patient who had osteitis pubis or marrow edema, and you can categorize this to minimal or less than 2.5 centimeter or more than 2.5 centimeter, in which case the patient needs a longer period of rest. This is a patient who clearly showed a lot of bony changes at the pubic symphysis, and the rectus abdominis and inguinal regions were normal. When we looked at the left side parasymphyseal, you saw that there is a secondary cleft that is extending into the short adductors. Prepubic plate delaminations are well seen, like in this case here, and these delaminations can often extend laterally. So in this case, you can see that the patient also had a secondary cleft along with the delamination of the prepubic plate. A good idea is to image the sports groin in a direction along the iliopectineal line. So you're either perpendicular to the pubic body or parallel to the pubic body. And it affords excellent resolution of the structures in this area. So here's a case. This is the T2 sagittal PDFS, and you'll see on this side is the orthogonal axial, and this is the axial oblique. So on the orthogonal axial, we can miss small area of marrow edema, not seen here well. And this is just going straight up and down the pelvis. Whereas on the axial oblique, which is aligned either perpendicular or parallel to the pubic symphysis, you can see the anatomy much better, and the prepubic plate is seen well. You can also see the marrow edema in a small spot very well. The coronal oblique can also be used, but I personally don't use it. It's great to look at the bone, and you should do it if you're expecting a bony avulsion of the adductor longus. This is the Thomas Jefferson University protocol, and we follow a 1.5T protocol in which we start with large field of view images of the axial PDFS, coronal stir, and axial T1 acquisitions. And then we go to small FOV, which is the axial oblique and the sagittal. I usually do not do a coronal oblique. This is a footballer with groin pain. Let's look at the findings. You see that there is marrow edema, and right away you know there's something's going on. But a coronal stir lends you an opportunity to look at varicoceles, maybe pubic bone fractures, the hip joint, femoral sided edema, any trochanteric bursitis, iliopsoas bursitis. You can even look at the ischial tuberosities, the SI joints, and you get like a bird's eye view of the entire pelvis. So this is what we usually start with. You can always go down to the axial, in which case you can look for any hot spots, edema, etc. In this patient, you can see a secondary cleft very well. You see the marrow edema, the osteitis pubis. And going down, you would like to look at the adductor longus and their symmetry and if there is any tear. The secondary cleft, as you see, has run into the short adductors here, the adductor brevis and the obturator externus. You can even see spine bone changes, calcific tendonitis, maybe even a small fleck fracture. In this case, you'll see that this patient had a tear of the adductor longus from the pubic bone as well as from its attachment to the prepubic plate. And you see this fluid cleft intervening. You also see that there is interstitial tears and tendinosis of the contralateral adductor longus, lending evidence to the fact that this patient had a chronic sports groin and now has come with an acute injury. So here are some bone changes which appear chronic. These are the acute injury changes. So it's a good idea to describe everything. This is the sagittal T2 of the same patient. I normally don't do a T2, but I had it. Here's the tear. The delamination looks complex. The tear extends into the triangular dark signal of the adductor longus, clearly telling us that there is an avulsion here. This is a 22-year-old cricketer. And even though we just saw a little bit of fluid at the right adductor longus origin, you'll see how both the tendons are asymmetrical in size, and most of the tendon was lying distally retracted and completely torn. The same patient, right away, you see that the rectus abdominis was asymmetrical, giving credence to the fact that the right side of the pelvis was weak. And the same patient, where you can see that the adductor longus is lying 2 centimeter distally. This was an interesting case. He's a 47-year-old cricket coach with right-sided groin pain. And you see the asymmetry of the recti, but you also see a fatty inguinal hernia. And this is probably a case where there was an actual hernia with fat protruding through it. When you look at it in coronal, you see the widening of the linea semilunaris on this side. You see the inguinal hernia. And an interesting thing was that the fluid cleft that tore through the adductor longus was also extending into the hernia, telling us that these structures are all connected. The tear was through the adductor longus and the pectineus, also extending into the adductor brevis. When we look at it in SAG, you'll see that this is the area of the fatty inguinal outpouching or the hernia. And this fluid cleft was continuous with the tears that we are seeing. Avulsion of the adductor longus seen well. And as we go centrally, we see the delamination of the prepubic plate. And as we go off center to the other side, we see that this adductor longus was normal. 24-year-old long jump player, this patient, the sports groin seemed all right, but as we went distally, the large chunk of adductor longus was lying torn, right? So sometimes the findings can be quite distal. You can also see a tear through the gracilis in this patient. So there was a 6 centimeter retraction, adductor longus tear, gracilis tear, pectineus tear, and strains of the adductor brevis. This is a 32-year-old footballer, and as you can see, there is a tear through the adductor longus in this patient. But this was a complex tear, and this also caused a bone fleck to fly off, and there was a tear that extended through the pectineus. So this tear had lateralized. So all in all, it's a good idea to look at these injuries, describe acute and chronic injuries separately, look at all the eminent structures, pubic bone, common aponeurosis of the rectus abdominis and adductor longus, look at the inguinal ring, follow MR protocols, use axial oblique imaging, and stay away from all sorts of heterogeneous taxonomy. If you don't find anything in the box, then find something out of the box, like in this case, this patient was a cricketer with right-sided groin pain, but in fact, he had a varicocele. This patient had an inferior pubic ramus fracture. On an MR, it also showed that there was a stretch injury of the superior pubic ramus. This patient was an avid tennis player. She came again with a bony avulsion of the medial head, the rectus abdominis. This patient was a dancer. He had left-sided groin pain. In fact, he had iliopsoas bursitis. This is a patient who repeatedly came for groin pain. In fact, he had a tear of the adductor longus from its distal femoral insertion, and the adductor longus was bunched up proximally, and every time he played, he came with strain pattern edema through the muscle belly. So please follow a structured reporting format. Try and describe all the osseous abnormalities. Look at the aponeurotic prepubic plate. Look at the rectus abdominis and adductor longus. Describe their symmetry, strain, tendinosis, partial and full thickness tears. Look at the rectus sheath and look at the short adductors. If you don't find something in the box, think out of the box. And describe acute injuries in the impression or the conclusion of the report first, and then mention the chronic injuries. I thank you very much for your time, and I thank the organizers for inviting me to AMS. Thank you.
Thank you, Dr. Nafisa, for a very insightful lecture. And for all participants who wish to ask questions to Dr. Nafisa, you could type your question in the chat box, and Dr. Nafisa will answer the question submitted. Now, dear participant, for the second speaker, let's welcome Dr. Ankur Shah. Dr. Ankur Shah is consultant radiologist from Sadbhav Imaging Center, India, and Dr. Ankur Shah will conduct imaging of articular cartilage, presence and future. Dr. Ankur Shah, the time is yours.
Hello, everyone. It is my pleasure to be a part of the annual conference of the Asian Musculoskeletal Society, and I would like to thank Dr. Paulos and the entire organizing team for inviting me for this talk. So, in next 20 minutes, I'll be discussing about the imaging of articular cartilage, the presence and future. We know articular cartilage, it is highly specialized connective tissue of the diarthrodial joints, and the principal function of the cartilage is to provide a smooth, lubricated surface for the articulation and also to facilitate the transmission of loads with low friction. As we know, the articular cartilage, it does not have the blood vessels, the lymphatics and nerves. So the capacity of intrinsic healing and repair is very less. MR plays very important role in the pre-operative evaluation of the chondral injuries, and it also helps in guiding the further management. The choice of the procedure, it depends on the site as well as size of the chondral lesion, whether there is bone, underlying bone is involved or not, whether there is presence of loose bodies, and what is the stage of the chondral injury. And all these answers can be given with the help of MR. The imaging of articular cartilage actually started in the era of radiograph also, which provided indirect signs of the cartilage loss, like the joint space reduction and the subchondral bony changes. However, it does not allow direct visualization of the cartilage, which is possible with the help of MR. It not just only shows articular cartilage, it also allows us to evaluate the exact extent of the cartilage injury. Before we go into the imaging, it is important to understand the composition of the articular cartilage. It is formed by the cells and the extracellular matrix. The cells, they form just about 1 to 2% of the cartilage, while rest of the part is the extracellular matrix, which has liquid phase and the solid phase. The solid phase is important because it has collagen, mainly the type 2 collagen, and proteoglycans, along with some other proteins. The proteoglycans, they contain negatively charged glycosaminoglycans, and which are important for indirect assessment of the proteoglycan content of the articular cartilage. The structure of the articular cartilage can be divided in different zones. There can be superficial, there is a superficial zone, the transitional or the middle zone, which is thickest, and the deep zone. And this zonal architecture is responsible for the little inhomogeneous or the layered appearance of cartilage on MRI. This is an MRI of the cartilage specimen, which is done on the 7 Tesla MR, where you can see the articular cartilage as well as the subchondral bone plate very nicely. So what are the techniques of cartilage imaging on MRI? We can divide them in different sets. There are some sequences which are useful for morphological evaluation. There are sequences which are useful for the compositional or the biochemical evaluation of the articular cartilage. And there is one more technique, that is the biomechanical imaging. Let's see them one by one. For morphological evaluation, the two most important sequences are the T2 weighted and the proton density. And when we add fat suppression to that, it gives better contrast at the subchondral bone and the cartilage interface. Importantly, these sequences are also useful for evaluation of the other structures of the joint. Like in knee joint, they are useful to see the menisci, the ligaments, as well as subchondral bone. So anyway, we are going to take these sequences, and additionally, we are getting all information about the articular cartilage using these sequences. There is one more sequence which is called as intermediate weighted sequence because it is between T2 and PD. The parameters are between T2 weighted and proton density with T of around 30 to 60 millisecond. This is a very nice sequence for evaluation of articular cartilage, as you can see, and there is very well differentiation of the cartilage and subchondral bone in this sequence. So this sequence is very widely used for cartilage imaging. One more important morphological sequence is the gradient echo sequence. It gives excellent visualization of the cartilage defect. It can be obtained as 3D imaging also with short scan time, and there is very nice spatial resolution. Unfortunately, these sequences are not very sensitive for detection of the superficial lesions because there is lack of contrast between the cartilage and joint fluid, and they are very much sensitive to susceptibility artifacts, and they don't give information about the other structures of the joint or the bone. So that is the limitation of gradient echo. Otherwise, even for smaller joints of like joints of hand and wrist, this sequence is very much useful to see the details of the articular cartilage and cartilage defect. T1 weighted image, though these sequences are not very useful for cartilage evaluation because there is not much difference between the articular cartilage and the joint fluid, but they are excellent for visualization of the sclerosis. Whenever there is subchondral sclerosis, it is very nicely seen with the T1 weighted image. For example, these are the fat suppressed proton density and T1 weighted images. The subchondral bone marrow edema-like signal intensity changes are very well seen on both the sequences, but the subchondral sclerotic changes, they are much better seen on the T1 weighted images compared to the fat suppressed proton density images. So that is the utility of T1 weighted images for articular cartilage imaging. Some other morphological sequences are SPGR, FLASH, there is T1FFE, and many more newer sequences like DEFT, DES, and all these sequences are isotropic 3D sequences with better delineation of the cartilage defects. But all these have longer acquisition time and they are not useful for evaluation of the other structures of the knee joint. So how do we grade the cartilage injury? There is no standardized MR classification system for the articular cartilage lesions, and the most accepted MR classification, that is the MR imaging adaptation of the arthroscopic classification, which is given by the International Cartilage Repair Society. So as per ICRS grading, grade 0 is the normal articular cartilage. Grade 1 is subdivided in grade 1A and 1B, where 1A are the intrinsic cartilage signal abnormalities without morphological changes on the surface. 1B is when there are some changes in the surface in form of subtle superficial fissures or lacerations. Remember, sometimes grade 1 lesions might be missed on MR because of the suboptimal resolution. Grade 2 changes are when there are chondral lesions which are affecting less than 50% of the depth of the articular cartilage. When they affect more than 50% depth, it becomes grade 3 lesion. And grade 4 is when there is full thickness cartilage defect along with subchondral bone changes. So when it reaches up to subchondral bone plate, then it becomes a grade 4 cartilage injury. These are the examples of all. The normal cartilage, 1A, when you see either hyperintensity or hypointensity within the cartilage. 1B, when there is superficial fissures. 2, when the fissures are involving little more depth but less than 50%. 3 is when it is involving more than 50%. It can be a short segment or it can be over the larger area of cartilage involvement. Even such kind of the delamination cartilage injuries, they are also termed as the grade 3 injuries. And grade 4 is when there is full thickness cartilage loss with subchondral bone marrow edema-like signal intensity or cyst-like changes. One more sign is described in cartilage injury, that is known as the cartilage black line sign. You must have seen such linear hypointense areas on the fat suppressed proton density or T2 weighted images, which are affecting cartilage without significant abnormality of the surface of the cartilage. And these are termed as the cartilage black line sign. On arthroscopy, these areas are found to be uh, showing focal cartilage fissuring on the arthroscopy. So these are usually the superficial lesions, either grade 1 or sometimes grade 2 cartilage injuries. And so don't ignore when you see such linear hypointense areas in the articular cartilage. With severe affection, there may be complete loss of articular cartilage, like here. There is complete loss of femoral articular cartilage. There is loss of articular cartilage in part of tibial condyle, and there are associated subchondral bone marrow edema-like signal intensities. The same changes are also seen in the patellar cartilage also. Some changes, they do not affect only cartilage, but sometimes they are also involving the subchondral bone. And one of those injuries are the osteochondritis dissecans. These are the osteochondral lesions which affect the bone as well as articular cartilage, and they can be either stable or sometimes unstable fragment. They are commonly seen in young males, and the most common site of involvement is lateral aspect of medial femoral condyle. Sometimes they can also affect the lateral femoral condyle, but classically seen in young individuals where you might see such kind of separated osteochondral fragment. Sometimes cartilage injuries can also occur after trauma. For example, this patient had a young individual. She had MR appearance of bone contusions involving anterolateral aspect of the lateral femoral condyle and the infromedial aspect of medial patellar facet. Many times they are associated with the injury of the medial patellofemoral ligament also. And if you look carefully, there is a focal cartilage injury, a cartilage defect with underlying subchondral bone contusion, that is the osteochondral injury involving the lateral femoral condyle. And this is classically seen in patients who had transient lateral patellar dislocation, which can be associated with the articular cartilage damage. Coming to the postoperative evaluation, once the cartilage is damaged and repaired, MRI also helps in evaluation of the post-operative articular cartilage. What is the status of the articular cartilage after the surgery is done? To understand that, it is important to understand which are the surgical procedures which are used for the cartilage injuries. They are in form of marrow stimulation. The different techniques are either by microfracture or by drilling. These marrow stimulation techniques, they result in formation of the fibrocartilage, which is little inferior quality cartilage compared to the normal hyaline cartilage. Another technique is osteochondral grafting, which can be either autograft or allograft. Here, an osteochondral graft is obtained from a non-weight bearing part of the joint, and then it is put at the site of cartilage defect. So we are just taking out the hyaline cartilage from one part and putting it in the other part of the joint. So it results in formation of the hyaline cartilage. Another important technique is cell-based repair, where again cartilage is obtained from the non-weight bearing part, then it is sent to the laboratory where it is grown, and this larger area of cartilage which we get, that is placed at the site of cartilage defect, and this results in hyaline like cartilage. So it is not hyaline, it is inferior in quality compared to the hyaline, but superior in quality compared to the fibrocartilage. Particularly when the defects are very large, then cell-based repair techniques are done. And there are some other repair techniques like bone marrow aspirate concentrate on scaffold, which also results in formation of the hyaline like cartilage. So how do we evaluate this post-operative cartilage with the help of MR? The technique which is described is known as the MOCART technique, that is the magnetic resonance observation of cartilage repair tissue. And this is a 7-point variable with different points are given to the appearance of the articular cartilage, and then the cartilage is evaluated. For example, whenever the postoperative MR imaging is done, we look for the volume filling of the cartilage defect, look for the integration into the adjacent cartilage, the surface of the repair tissue, the structure of the repair tissue, the signal intensity of the repair, what is the status of bony defect or bony outgrowth or overgrowth, or whether the subchondral changes are present or not. All these are given different points. The total point number is 100, and higher the points, the better is the post-operative articular cartilage status. If the points are very less, that suggests there is a poor cartilage integration or the poor outcome of the surgery. This is same thing in the diagrammatic manner, where we evaluate all these 7 points and then give the Mokart score. This is one example when the preoperatively there was a defect, and after that the osteochondral autograft was done, and you can see there is very nice integration of the bone graft with the adjacent cartilage. It is little prominent, but that is fine. As per the Mokart, this gives a very high score and suggests good status of the postoperative articular cartilage. We can also evaluate the donor site also with the help of MRI. Coming to the second evaluation, that is the biochemical imaging. The aging cartilage and the osteoarthritis, they both are not same. In osteoarthritis, there is increase in the loss of proteoglycans, there is loss of water, and there is increase in the collagen compared to the normal or aging cartilage. And the loss of proteoglycan from this extracellular matrix, this has been hypothesized to be the event which initiates the onset of the osteoarthritis. So which are the sequences which are used for the biochemical imaging? That is T2 mapping, which is useful for evaluation of collagen. There are other techniques which are useful for evaluation of proteoglycans, that are DJAMRIC, sodium imaging, and CEST imaging. There is one more which is T1 row imaging, which is influenced by the both proteoglycans as well as collagen. Why are we checking for all this? Because glycosaminoglycans loss is reversible at early stage. So if we detect it early, we can prevent further osteoarthritis. Starting with the T2 mapping, this is affected by the water as well as collagen content of the articular cartilage. And this is helpful to evaluate zonal differentiation of articular cartilage after various operative procedures. T2 mapping is extremely useful for evaluation of post-operative cartilage, whether there is formation of hyaline cartilage, hyaline-like cartilage, or fibrocartilage, because all these, they look similar on the morphological evaluation. This is the T2 mapping of a damaged articular cartilage. This is pre-operative, where you can see the cartilage defect, and the T2 values are different in the areas of defect as well as adjacent articular cartilage compared to the normal healthy articular cartilage. And this is for the post-operative MR. When this patient was treated with microfracture, the another patient was treated with MACT, and as you can see, the cartilage which is formed are of different quality. With microfracture, there is formation of the fibrocartilage, which shows different T2 signals and T2 values compared to the cartilage which is formed by the MACT. So that is how it helps us in differentiating the quality of the articular cartilage which is formed after the surgery. A young basketball player, MRI obtained after 3 months after the microfracture, and you can clearly see the cartilage which is formed, though it looks similar on the morphological evaluation, but T2 mapping shows that this cartilage is of different character compared to the normal hyaline cartilage, because this is the fibrocartilage that is formed. Coming to the DJAMRIC, that is the delayed gadolinium enhanced MRI of the cartilage. This is a type of T1 relaxation measurement after the intravenous administration of gadolinium and estimation of its penetration in the articular cartilage after sufficient time. How do we do that? The glycosaminoglycans, they are negatively charged side particles of the side chains of the proteoglycans. And this helps in their indirect evaluation with the help of post-contrast MRI. Because gadolinium, this is also negatively charged. So when there is loss of glycosaminoglycans, the negatively charged gadolinium, it takes place by the diffusion into the cartilage and sits at the same site. And then once we do an MRI and subtract the images from the pre-contrast MR images, we get all the details. This is seen as areas of decreased T1 relaxation value on the delayed images because the gadolinium is deposited at all these sites, and that is inversely proportionate to the amount of glycosaminoglycans. So if the glycosaminoglycans is more, then the deposition of gadolinium will be less. If there is more loss of glycosaminoglycans, so the concentration is less, then there will be more gadolinium which will be deposited at its site. Because this process of diffusion is very slow, we need to give sufficient time between the intravenous gadolinium contrast and the imaging of the joint. So that is usually 2 hours for the femoral articular cartilage. The advantages are there is high sensitivity and better resolution compared to the sodium MRI. But it has disadvantages also. It needs intravenous contrast, that is usually double the dose compared to the routine MRI. The procedure time is longer, that is around 2 hours, because we need to give delay after the injection of the contrast. And for thicker cartilage like patella, this can be as long as 4 hours. And there is no standardization of the exercise which is usually done during this time to help the deposition of the gadolinium. So another important technique which helps in evaluation of the glycosaminoglycans is the sodium MRI, where instead of proton, we are using sodium to generate the signals. And this can estimate the concentration of glycosaminoglycans non-invasively even without any injection. The amount of sodium in the cartilage matrix that correlates with the amount of glycosaminoglycans. Because the glycosaminoglycans are negatively charged, the sodium is positively charged. So to maintain the electroneutrality, both have same concentration in the articular cartilage. So if we measure sodium, we are in a way measuring the amount of glycosaminoglycans. But there are some challenges in sodium MR. It has very less frequency, that is 1/4 compared to the hydrogen. The concentration is very less. The sensitivity of sodium MR is just 9.3% compared to the hydrogen MR. The signal to noise ratio, ultimately what we get is very, very less. And that is why the resolution is also lower even with longer acquisition time. So though it has advantages like it gives direct estimation of the fixed charge density and the amount of proteoglycan content in the matrix, which is not influenced by any other component, it is very sensitive even with small changes in the glycosaminoglycan content without giving any intravenous gadolinium, and also utility to detect the quality of the articular cartilage after the repair procedure. But the limitations they use, they are the reason why this technique is less used, because we need the separate equipment in MR machine to generate the frequency, because it works at different frequency, not hydrogen but for the sodium. We need ultra high field strength MR, that is 7 Tesla, because the SNR on 3T is extremely low. Even with 7 Tesla, the SNR is low. It needs special sodium coils with transmit and receive array, and the spatial resolution is low even with longer scan times also. So some other techniques are also tried, like GEXEST. This works on the principle of chemical exchange saturation transfer, which gives estimation of the proteoglycan content non-invasively. There is exchange of the labile hydroxyprotons on the glycosaminoglycans with the bulk of water, which results in creation of the GEXEST. Because this value is very small, again, we need a very high strength machines like 7 Tesla. And this value is even less in patients who have less amount of glycosaminoglycans. The other challenges are they are extremely sensitive to the motion as well as magnetic inhomogeneity. So CEST MR is non-invasive, no IV contrast is needed, and it has potential to measure the proteoglycan content with accuracy, but it has disadvantage that we need ultra high field magnet of 7 Tesla with longer scan time of about 20 minutes and extreme sensitivity to motion artifacts. It is affected by the magnetic inhomogeneity, and that is why the CEST values are sometimes difficult to calculate, particularly in thinner cartilage like the tibial articular cartilage. The values are even less. One more technique is T1 row imaging. It was initially very much popular, but gradually we have found that this is not extremely useful, because again, it is affected by not just proteoglycan content but also the collagen content of the articular cartilage. Lastly, biomechanical imaging. When the joint is unloaded, that is imaged after rest of about 20 to 30 minutes, there is increase in the T2 value of the articular cartilage, possibly because of there is influx of water which was squeezed during the time of weight bearing. So changing weight bearing can even change in the collagen architecture also. So the T2 map can be changed. So once we scan a patient with some special devices which can give load, we can give almost visualization of the cartilage status, which is like a patient is standing and weight bearing position, which can help us in understanding certain cartilage injuries which or certain pain which patient feels only while standing. So to take home, MR is the modality of choice for imaging of the articular cartilage. There is no doubt about that. There are different MR sequences which help in the morphological evaluation of the cartilage with very high accuracy. The biochemical imaging methods, they are useful for evaluation of the composition of the cartilage, particularly after the surgery, and they can detect osteoarthritic changes early. And possibly, this could be the future of the cartilage imaging. Thank you so much.
Yeah, thank you, Dr. Ankur Shah, for bringing us a very insightful presentation. And for all participants who wish to ask question to Dr. Ankur Shah, please type your question directly to the chat box. Okay, the third speaker for plenary session is Professor James Griffith. Professor James Griffith is the professor of the Department of Imaging and Interventional Radiology, the Chinese University of Hong Kong, Prince of Wales Hospital, Hong Kong. Professor Griffith will present us a lecture about brachial plexus ultrasound, an underutilized technique. Professor Griffith, the time is yours.
Hello everyone and welcome to this lecture on ultrasound of the brachial plexus and underutilized technique. My name is James Griffith from the Chinese University of Hong Kong. Before we start, I'd like to say a big thank you to Paulus and his team for putting on this wonderful program and also for inviting me to give this lecture. I hope that by the end of this lecture, I can have persuaded you that we should be doing a lot more ultrasound of the brachial plexus. It's an extremely useful technique. If I've got the choice of doing an ultrasound or an MRI of the brachial plexus, I'll choose ultrasound any day because I find it provides a lot more useful information, is a lot more efficient. Now, a lot of people are put off by ultrasound of the brachial plexus simply because they're concerned or they're perplexed by the brachial plexus anatomy. Well, there's no need to be perplexed by it. The brachial plexus anatomy is very variable. Oh yes, of course, you've got the roots, you've got the trunks, you've got the divisions, the cords and the terminal branches. But how these come together with respect to dividing and uniting again is extremely variable. So you just need to sweep down the brachial plexus in a transverse plane and, just evaluating the cords, the roots, the trunks, the divisions, the cords and the terminal branches as you go along, but without doing specific measurements or any other features. We normally will start with the normal brachial plexus. Usually patients will have only one affected side or a least affected side. So we'll start with that and then go on to the affected side. Now, of course, the intraforaminal portion of the brachial plexus cannot be visualized with ultrasound, so you do need MRI to evaluate the rootlets and the intraforaminal portion of the brachial plexus. For the extraforaminal portion, you scan typically in a transverse plane, starting at the neck region, going down towards the clavicle. When you reach the clavicle, just put the patient's arm into a 90 degrees abduction to look at the immediate infraclavicular region of the cords, and then abduct the arm fully to look at the terminal branches in the axilla. This is your go-to image. When you're scanning the lateral side of the neck, you can see the traffic lights are the three trunks between the scalenus anterior and the scalenus medius. You recognize the scalenus anterior because, of course, it's next to the jugular vein and the carotid artery and the thyroid gland. And the scalenus medius then is posterior to that, and you can see the three trunks. But this is quite variable, and you don't always see three distinct trunks like this, upper, middle, and lower trunks. Then you can follow the individual trunks backwards to look at the exit foramina. Now, this is kind of less important, but it's certainly useful to do. You recognize C7 by having the thumbs up sign, where you've got a posterior tubercle, but you don't have an anterior tubercle at C7, and this is a C7 root here. Then you can scan up from C7 to look at C6, and at C6 you've got the V sign, and the root in between the two anterior and posterior tubercles. Then you can scan up to look at C6, and essentially the V gets smaller and smaller as you go up to look at C6, C5, and C4. Then you can go back to your intrascalenus region again and follow it more distally along the region of the divisions. And you'll see all of these lined up alongside the subclavian artery, and this is known as a bunch of grapes sign. Now you can follow the bunch of grapes down towards this immediate supraclavicular area, and here's the subclavian artery, and here you can see the divisions lined up just before it goes underneath the clavicle. And the clavicle, or the costoclavicular gap, is the narrowest portion of the brachial plexus, and that's where most compression can occur in people with clavicular fractures or rib fractures, etc. Here also the subclavian artery becomes the axillary artery as it passes over the first rib. Now, and then you can abduct the arm into just 90 degrees and scan in the immediate infraclavicular region, and you'll see the axillary artery, and then a bit deep to the pectoralis muscles, and then you'll see the three cords, the lateral, posterior, and middle cords of the brachial plexus in that region. That's probably the hardest part of the brachial plexus to examine. You don't need to individually see the three components. You just need to see the axillary artery and see the region around the axillary artery and make sure that there's no severe fibrosis or mass lesion present in that area. The individual components don't need to be necessarily seen. Then you scan into the axilla, you track the brachial artery proximally in the arm and track it proximally. And when you see the musculocutaneous nerve between the biceps and the coracobrachialis muscle, then at that level, you can identify the axillary artery. And then the medial nerve is always closest to the artery or to the muscles. The ulnar nerve is away from the muscle, and the radial nerve tends to lie more posteriorly. So that configuration is a consistent finding in this region. So each brachial plexus ultrasound examination can be done extremely quickly. You can scan both sides in honestly less than 5 minutes. But normally it would take about 10 minutes to complete the ultrasound examination of both brachial plexus, but it's a very quick and very reliable examination in vast majority of cases. Now, these are all the pathologies that you can look for on brachial plexus ultrasound, and let's go through some of these. Nerve sheath tumors are one possibility or one pathology. 90% of nerve sheath tumors of the brachial plexus are, 90% of tumors of the brachial plexus are nerve sheath tumors. 90% of these are benign and 90% are schwannomas. And ultrasound is useful for diagnosing these tumors, which can be made with absolute certainty, provided you see neural continuity and all of the other signs of a nerve sheath tumor on ultrasound. Brachial plexopathy or radiation plexopathy is a common indication patients present with upper limb symptoms. We're asked to confirm or to determine whether it's radiation plexopathy or whether there's metastatic infiltration of the brachial plexus. This is what a normal divisions look like. You can see all the divisions of the brachial plexus. You can see the normal fat, and on ultrasound, this fat will all look quite soft between the divisions of the brachial plexus. Whereas in radiation plexopathy, you can see the nerves are very difficult to define, and the fat in between all of these areas is very dirty and fibrosed. This is moderate severity or moderate to severe brachial plexopathy. This is, again, you can look at the normal side for comparison, and in patients with unilateral radiation therapy, you can readily compare it with the normal side. As you can see here, this is the affected side. You can see in the intrascleneous area, you've got scalenus anterior, scalenus medius, and you can see the trunks are very poorly delineated with severe fibrosis of the intervening fat due to severe brachial plexopathy. Very, very similar to the appearance that you'll see on MRI. This is MRI of the subclavian region. You can see the artery, the veins, and the brachial plexus, as well as subclavius muscle. And in this patient with brachial plexopathy, you can appreciate the severe fibrosis around all of the nerve roots in this area. So the ultrasound signs of brachial plexopathy really are increase in size of the individual components, poor delineation surrounding fat, which is dirty or obliterated, clumping of the individual components. You may see hyperemia and color Doppler imaging, and generally you get the impression that tissues are quite stiff. Now, the question that always arises, is this due to metastatic infiltration or brachial plexopathy? Well, essentially with metastatic infiltration, you'll see a discrete mass within the brachial plexus. The larger the mass or the more discrete the mass is, the more likely it is to be metastatic infiltration. It may not necessarily be hyperemic, but if it is, that's a useful sign. And often, or not infrequently, you have to biopsy this mass if it's present to make the distinction between, nodular radiation plexopathy and metastatic disease. There's no problem with biopsying a tumor in the region of the brachial plexus. I've done that many times without any ill effect. But essentially what you're looking for is a mass in the region of brachial plexopathy, in the region of the brachial plexus, to ascertain whether there's metastatic infiltration. So metastases are more likely if there's a discrete mass, if the mass is hyperemic, if there's adjacent metastatic nodes, and you often do need to biopsy it to confirm the diagnosis. Now with trauma, of course, you need to do an MRI scan because you need to, one thing you've got to evaluate with trauma is whether this is a preganglionic or postganglionic injury. Preganglionic injuries cannot be treated surgically, but postganglionic injuries may potentially be amiable to surgical intervention. What you will see on MRI, and you cannot visualize these things with ultrasound, you may see disruption of the rootlet due to avulsion, with changes within the cord, with swelling and hemosiderin deposition and irregularity of the cord at the affected side. Or you may see evidence of a pseudomeningeal seal, which essentially means the dura is torn in this case. Now, as you can imagine, not all dural tears have got nerve root avulsion. And similarly, you may get nerve root avulsion without a dural tear, but overall it's a good sign for nerve root avulsion. And in this case, you can appreciate that there's some subtle swelling of the cord also in this area. Now, you cannot evaluate that with ultrasound, so that definitely is a limitation of ultrasound. But for evaluation of the extraforaminal brachial plexus, ultrasound is excellent. This is one such case, a young man who had a road traffic accident with a traction injury to his arm, severe upper limb weakness afterwards. This is the MRI scan. All you could say is that there is likely to be an injury of the brachial plexus in the region of the divisions and the cords of the brachial plexus. That's all you could say on MRI examination. You couldn't be more specific. So in a patient like this, we'd do an ultrasound examination. This is the ultrasound examination of the proximal arm region. Here's a normal side. You can see the normal musculocutaneous nerve between the biceps tendon and the coracobrachialis tendon, whereas on the affected side, you can see the musculocutaneous nerve is very swollen compared to normal. On longitudinal section, again, this is the musculocutaneous nerve and the normal side, and on the affected side, you can appreciate that's very, very swollen due to a severe traction injury to that nerve. Also, we brought the patient back for rescanning about a month later. The musculocutaneous nerve was very similar in appearance, but when we looked at the region of the cords, we could see that there was swelling in the region of the posterior cord, and on longitudinal sectioning, we hadn't appreciated this initially, but you can see that there's a neuroma in continuity with focal swelling of the nerve due to an incomplete transection of the posterior cord. And the patient subsequently went to surgery, and both of these findings were confirmed with a neuroma in continuity of the posterior cord and a severe traction injury to the musculocutaneous nerve. So you can appreciate that ultrasound allows you to have a much more definitive and specific assessment of the brachial plexus compared to MRI in extrabrachial or extraforaminal brachial plexus injury. Parsonage-Turner syndrome, or more commonly known as neuralgic amyotrophy. The principal sign really is denervation of the affected muscles. And again, this is one which tends to be relatively difficult to evaluate with ultrasound examination. With ultrasound examination, you're looking for neural thickening, particularly of the suprascapular nerve, but all of these nerves may also be affected in the brachial plexus, long thoracic nerve, axillary nerve, and it often affects nerves also outside the brachial plexus. So that's the beauty of ultrasound, that you can evaluate the nerves outside the brachial plexus, such as the radial nerve, median nerve, and the anterior and posterior interosseous nerves, which commonly tend to be affected. What you're looking for is focal nerve swelling, plus or minus an hourglass constriction, and also muscle denervation. But muscle denervation is difficult to see unless severe on ultrasound. This is one such case, a patient with wrist drop, and numbness in the dorsum of the hand. Suspicious of a radial nerve palsy. On the affected side, you can appreciate posterior to the humeral shaft in the region of the radial tunnel, the radial nerve is diffusely swollen compared to the contralateral side, the normal appearance on the contralateral side. And then more distally on MRI, you could appreciate moderate denervation of the supinator muscle, as well as to a lesser extent the brachioradialis muscle, which also showed mild fatty atrophy. Now, in these cases where you've got a swollen nerve, you must look at the nerve in longitudinal section, because occasionally you may get an hourglass constriction of the nerve, as you can see here. And this is an important thing to recognize, because it needs to be treated surgically. The reason why the nerve constricts is because when the nerve becomes very swollen as a result of neuralgic amyotrophy, with normal physiological movement, the nerve may twist, and because the nerve is swollen, it will not twist back in itself again, and you get this focal compression of the nerve. So that needs to be treated surgically. And so ultrasound, whilst it cannot evaluate muscle denervation, is excellent at evaluating extraplexal nerves, which may be affected by neuralgic amyotrophy. What about our experience? So far we've done ultrasound before MRI in about 93 patients. And in 91 or 98% of these cases, ultrasound was completely concordant with the MRI, subsequent MRI findings. In 3/4 of the, or 2/3 of these cases, ultrasound and MRI were completely normal. So don't be perturbed if you're doing both ultrasound and MRI of the brachial plexus, and a large number of the MRI or ultrasound examinations are normal. This is also our experience, and it's simply because it's very difficult clinically to localize an abnormality to the brachial plexus. Now, of the abnormal cases, ultrasound and MRI were concordant in the vast majority of these cases, like radiation fibrosis, tumor, trauma, inflammatory polyneuropathy, neuralgic amyotrophy, and metastatic infiltration. 2 cases were missed by ultrasound, neuralgic amyotrophy and inflammatory polyneuropathy. So overall, the sensitivity of ultrasound and for brachial plexus pathology was 94%, with a specificity of 100%. So overall, ultrasound is a very good screening investigation for brachial plexus pathology. If there is a strong clinical suspicion, then MRI may be helpful in certain instances where ultrasound is negative, particularly if neuralgic amyotrophy is suspected or an inflammatory polyneuropathy clinically. I hope that you'll agree that for imaging the brachial plexus, ultrasound and MRI are the best of friends. MRI is excellent for intraspinal pathology, whereas ultrasound is excellent for extraspinal pathology. Overall, MRI tends to be overutilized in this respect, while ultrasound tends to be underutilized. Thank you very much for your attention.
Yeah, thank you, Professor Griffith, for a very wonderful lecture. I think this lecture will help us very much, especially for radiologists here in Indonesia. Yeah, and for all participants who wish to ask questions to Professor Griffith, please directly type your question in the chat box, and the presenter, Professor Griffith, will answer the question submitted. And the fourth speaker is Dr. King Kenneth Chung. Dr. King Kenneth Chung is the clinical assistant professor of the Chinese University of Hong Kong, and Dr. King Kenneth Chung will deliver lecture about dual energy city in MSK, beyond crystal and marrow edema. Dr. Chung, the time is yours.
Hello, my name is Kenneth Chung, and I'm a MSK radiologist based in Hong Kong. It's a shame that I can't be there with you in person this year. Hopefully we can meet in person and face-to-face in next year's conference. First of all, I'd like to thank the organizing committee for inviting me to give this talk. And my topic today is on dual energy CT in MSK. And I've specifically chosen not to include crystal and bone edema detection in this talk, because I think for the past few years or so, we're getting more and more used to seeing pretty pictures such as these. That's becoming rather routine. So here, for example, gout detection in the knee, and also for bone marrow edema detection in occult fractures, such as this case in the superior pubic ramus. So I think there are plenty of literature and talks covering these topics, and therefore what I would rather do in this talk is to highlight and also bring awareness to some of the other less well-known applications and techniques of pure energy CT, and hopefully that would give you some flexibility and also to smooth and streamline some of your workflow in your day-to-day practice. So I'm going to spend a few slides just to cover the basis of energy CT, and I think that's important for us to fully appreciate the subsequent indication and applications that I will demonstrate in some of the cases. Then I'd like to introduce my patient 0, who is basically the patient that started my journey down the energy CT in MSK, and also learning mistakes from the process. And hopefully I could share that with you so that you won't make the same mistakes with me again. And lastly, I will demonstrate a couple of cases just to highlight some of the usefulness and some of the techniques available, especially to do some troubleshooting and us actually providing opportunity for streamlined workflows such as a one-stop shop. I'm going to do that by showing some arthrograms as well as myelograms, and also demonstrate the possibility of reducing metal artifact further using some of the dual energy CT techniques. And I'd like to emphasize at this point that everything I'm showing here, they are off the shelf, they're commercially available using, in our institution, a Siemens system with single via and a drive dual energy CT system. And so these are all ready to be implemented. And hopefully by the end of the talk, then I will convince you that there is a place for these applications and that you can roll out to your clinical practice with ease. So to introduce some of the dual energy CT techniques, there are essentially two main techniques that I find very useful in MSK. The first one being virtual non-contrast. That's where we can actually separate the iodine contrast from other body parts and material in order to suppress the signal and therefore digitally removing the contrast. And the other technique is virtual monoenergetic imaging, or VMI, and they essentially try to extrapolate what the image will look like at different kV and energy from your dual energy system. And that gives rise to applications such as contrast optimization as well as metal artifact reduction. So here's a graph essentially illustrating the basis of dual energy CT. So in the vertical axis here, we have the Hounsfield units acquired at a lower kV, and the horizontal axis, the Hounsfield unit acquired at a higher kV. So for materials like air and water, the Hounsfield units don't really change much with varying kV. But as you can see here with iodine, it demonstrates a very different attenuation profile at different kV levels. And it's this difference between the material at different energy levels that allow us to separate or to decompose these individual materials. And that gives rise to possibility like virtual non-contrast, where we can separate the iodine contrast away from other body parts. And the same could be applied to calcium, so non-calcium imaging, because as you can see here, calcium also has a very different dual energy profile compared to other soft tissues. And another property that we try to exploit from dual energy is the behavior of iodine. And in essence is attenuation profile at different kV levels. So in this graph on the left, the horizontal axis demonstrates the kV levels, and the vertical axis is the Hounsfield unit. And we have three different concentration of iodine contrast here. The light blue being the lowest concentration, and the darker blue being the highest. And water and soft tissue has a fairly linear and horizontal profile with a relatively low Hounsfield unit. So you can imagine in a single energy system where we're acquiring images typically around 120 kV, then if you have a very low iodine concentration, then the difference in the Hounsfield unit between that and adjacent soft tissue is minimal, and therefore giving you very suboptimal contrast opacification. And if that's the case, then in a single energy system, then there's no way back really. You're stuck with your single source image. Whereas with a dual energy system with VMI technique, it's possible to actually vary the kV virtually. So here we can actually put it all the way back, let's say to 60 kV, and immediately you can see because of the behavior of the iodine having high attenuation with lowering kV, then the Hounsfield unit actually increases, and therefore the difference in Hounsfield unit between the iodine contrast and soft tissue and water is much bigger than compared to a high kV level. So allowing you to optimize and to salvage the contrast visualization in cases where the iodine concentration level is suboptimal or low. And here are some images demonstrating that effect. So conventional image, you can see the kidneys medulla being quite bright, while in the aorta, the contrast opacification is intermediate. And if we dial the kV all the way back to 40 here, in this case, you can see how much brighter the iodine contrast appears in the aorta. And with increasing kV, and the iodine becomes less and less dense, and therefore the differentiation with adjacent soft tissues become less and less. So here's my paper. I've started my journey down my dual energy CT path, and also learning some mistakes throughout. She was a 17-year-old lady with quite a sizable medial talar dermostochondral defect, as you can see here in the radiolucency on this radiograph. So our friendly orthopedic surgeons performed a bone graft and a cartilage plug harvested from the medial malleolus, and she made a reasonably uneventful immediate post-operative recovery. But then about 6 months down the line, she became more and more symptomatic. So we decided to do a conventional MRI just to have a look to see what happened. And so this is what we saw. Here's the graft, and here, just under the graft, there seems to be a fluid signal cleft that seems to undercut the graft itself. And on the PD images, you can see the interface between the graft and the native bone is quite irregular. So it's quite difficult to tell whether actually this is adequate healing, or if in fact there is still some residual non-union between the graft and the bone, and even more worrying whether this is becoming unstable. So we decided to perform a combined CT and MR arthrogram just to look into this further, and hopefully that could demonstrate any undercutting of the graft, and also to assess the articular surface a little bit better. So here's the arthrogram. I'm just going to zoom in a little bit better. So here you can see that there is quite a lot of T1 hyperintensity at the junction between the graft and the native bone. And that was quite concerning because it looked quite real, and it seems to be extending to the articular surface. But when we had a look at the CT, then it tells a slightly different picture. So here we're actually seeing some hyperdense stuff here that's curvilinear. The seemingly prominent contrast cleft undercutting the graft is not really that apparent, although when we actually scroll a little bit further, then some of the contrast cleft seems to be more apparent and extending to the articular surface, broadly corresponding to this defect seen on MR. But then I started kicking myself at this point, because it's actually really difficult to tell what's bone within the bone graft, especially here when there seems to be some contrast that's continuous with what might be bone or what might be contrast. And with a single energy system, there was simply no way of telling the difference apart from trying to correlate that with the MR. So this low signal focus here on a fat saturation sequence might actually correlate with the bony component of the graft itself. But we'd like to be certain. And it was at this point that I thought, what if I actually did a dual energy CT? That would have allowed me to remove the contrast, so I can then tell what is contrast and what is bone, and to be able to really see whether this is an unstable graft or not. And also I could have performed VMIs to increase the contrast visualization. So just to be even more confident where there is a real cleft defect on the medial side of the graft. Now, lucky for us that she actually had a baseline non-arthrographic CT a few weeks before in a different institution. So therefore, we could have correlated this. And so as you can see here, most of the curvilinear hyperdensity actually represent the bony component of the graft. But then there are actually definitely a little bit more hyperdense material here, extending more laterally and here to the articular surface. So telling us that there is, in fact, a true contrast cleft through the graft and bone interface. So it was from that point that I started performing geoenergy CT with our arthrograms with quite promising results, and it basically got me out of trouble many times. Here's one example with a hip arthrogram. So with your typical single energy image that's produced virtually from a geoenergy system. So you can see that the bone are bright, and then also the contrast is bright as well. And at the posterior labrum here, you can see that there is seemingly hyperdensity through the posterior labrum here. So on the standard images, it's really, really difficult to separate the two. So this intrasubstantial hyperdensity could be ossification, but it could also represent a horizontal labral tear with the contrast seeping through. And of course, when we apply virtual non-contrast technique, taking away all the contrast, then you can be very, very confident that this, in fact, was just ossification of the labrum with a bit of osteophytes at the edges. Another big plus of geoenergy in the shoulder, for example, is that we can remove the contrast altogether to allow us to perform 3D recon. So with shoulder instability requests, we typically do combine MR and CT because our surgeons quite like the CT for more in-depth bony assessment to prepare for any surgery if necessary. So with a standard arthrogram without geoenergy, this is a very familiar picture with contrast in the joint, and there's just no way to perform 3D bony recon in this case because all the contrast will be of similar density to the calcium, therefore making your 3D rendering completely useless. With the geoenergy, however, we can perform virtual non-contrast, removing all the contrast in the joint and allowing us to perform a 3D render with proper assessment of the glenoid. And it's really quite straightforward to do. And just got a short video here demonstrating how we do this under the single VIR system. So you choose your virtual non-enhanced profile under geoenergy application. Then here you're presented with a glide bar here. So there's an overlay of what it thinks would be contrast. So you can actually assess the contrast field area. Then you can see there's still some signal from the contrast. So what I've done here is just to play around with the RD ratio here a little bit. So in this case, I've lowered the RD ratio slightly to 2.8, and then you can see the effect. And there's further suppression of the RD contrast. And therefore, from this virtual non-contrast image, we can export that back to PACS and to perform further 3D recon. Another big plus with virtual non-contrast is, again, its ability to separate iodine and bone. And if I were to tell you there is a loose body here, on this image alone, there's no way of telling where it could be. But of course, with virtual non-contrast, we suppress all the iodine signal, and then the small osseous loose body at the posterior recess becomes very, very easy to see. So again, it gets you out of trouble a lot of times. In the spine, we don't do this very often, but we do get a few cases throughout the year where patients might have MR incompatible devices, so they will have to have a CT myelogram. And this is of an elderly lady. She was quite frail, didn't really tolerate the lumbar puncture well, and we couldn't inject as much contrast as we were hoping for. And this was for a C-spine as well as a lumbar spine myelogram. So the lumbar spine had reasonable RD contrast, and we can make use of that. But the C-spine was a bit tricky because it was very difficult for her to try to, for example, get into the head down position and to roll her around in order for the contrast to really diffuse throughout the CSF space. So the initial image, quite poor RD opacification. There was some at the upper thoracic level, but the cervical level is pretty much non-diagnostic. And by doing dual energy CT, then that gave us a lot of flexibility. So we could dial down the KV level, for example, here, back to 80. Then you can see immediately that the contrast signal is markedly improved, making these images, I would say, diagnostic at this point. And if you want to increase the contrast visualization even further, then you can try to dial back the KV, and in this case, back to 60, and even better contrast visualization. So very useful for contrast salvage, where, for example, the patient couldn't tolerate adequate amount of iodine contrast injection or administration. And again, in a single energy system, you would have been stuck with the original image and therefore not being able to make much use of the images. So again, a lot of flexibility, and again, would get you out of trouble. And here, just a few more images showing the difference between the two, and it's really quite striking. And another video to demonstrate to you how easy it is to do. So in here, you can select a C-spine as your profile, or you can select VMI. And again, you're presented with a slide bar at the bottom. And here you can see that at this moment, the energy level is at around 100 kV. So by dialing this back down a little bit, let's say to about 100, then you can see the contrast within the spinal canal itself becoming much, much brighter. And as we dial it back to 80, and it's even better. So very, very easy and simple to use. And finally, a little bit about metal artifacts. I think most systems now with their MARS algorithm, they do a very excellent job. And in Siemens, the IMER give us very good result. But if you were to improve that even further, then again, by using dual energy, you have the option of increasing your KV with VMI and reducing the metal artifacts even further. So a couple of examples here, that's the ankle with a lot of internal fixation plates and screws. So at a lower KV images, so at 60 kV, you can see there's just a lot of artifacts. Whereas if we increase the KV to 100 and then finally up to 140, then you can see that. Sorry, you can see that. I've lost my cursor here. Sorry. You can see that the amount of artifact has significantly reduced. And for example, the syndesmosis here can be much better seen, and also the soft tissue around the metal implants much, much better as well. So that brings me to the end of my talk. So hopefully through the past 15-20 minutes or so, I've been able to convince you that there is definitely a place for dual energy CT and MSK. I would say not everyday practice, but definitely it can be used for troubleshooting and also to streamline your workflow. And I've shown that it's very easy to implement in most systems. It's particularly useful when you need to differentiate between contrast and bones, or in situations where you think contrast visualization may be suboptimal, and also when there is a lot of metal involved. And it's a very, very great tool, providing a lot of flexibility. So you have a lot of post-processing opportunities that provides you with a lot of troubleshooting power, and potentially set up one-stop solutions. For example, in an arthrogram, where we would not need to bring the patient back for a non-contrast CT for only recon or for looking at loose bodies. So thank you very much for your time, and I hope you enjoyed the talk. I would love to hear any questions that you may have.
Yeah, thank you, Dr. Chung, for the interesting lecture. And for participants who wish to ask question to Dr. Chung, please directly type your question in the chat box, and Dr. Chung will answer the question for you. And our last speaker for the plenary session is Professor Tamotsu Kamishima. Professor Tamotsu affiliation is Hokkaido University, Japan. And Professor Tamotsu will give a lecture about imaging of the congenital spine disease. Professor Tamotsu, the time is yours.
Good morning, ladies and gentlemen. My name is Tamotsu Kamishima at Hokkaido University, Japan. My topic today is imaging of the congenital spine disease. Congenital spinal disease is divided into hereditary disease and congenital anomalies. I will touch on neurofibromatosis, this time type 1, and achondroplasia for hereditary diseases, while Chiari malformation, Klippel-Feil syndrome, supina bifida, anterior sacral meningocele, and caudal regulation syndrome for congenital anomalies, respectively. Let's start with neurofibromatosis type 1, or NF1. NF1 is a nevus and neurocutaneous syndrome characterized by pigmented spots such as cafe au lait macules and neurofibromas such as cutaneous neurofibroma. It is an autosomal dominant genetic disease in which various lesions appear in the skin, nervous system, and other organs such as bones, eyes, adrenal glands, and digestive organs. Various clinical symptoms appear. This NF1 patient had a back pain. The middle thoracic spine on T2-weighted sagittal and horizontal images show cystic dural dilatation centering on TH427 and scalloping in the vertebral bodies. The horizontal section shows lateral meningocele formation to the right, which was diagnosed as meningocele due to NF1. Another hereditary disease in this talk is achondroplasia. Achondroplasia is a representative skeletal dysplasia presenting short stature with short limbs and occurs in about 1 in 20,000 live births. Inheritance is autosomal dominant, but about 90% or more are due to new mutations and are born from healthy parents. This is a 13-year-old female with scalloping deformity due to achondroplasia. This woman in her early teens had intermittent claudication during follow-up for achondroplasia, and an MRI was taken for further investigation. A T2-weighted sagittal view shows a depressed deformation on the dorsal side of the vertebral body, which is a finding of scalloping deformation. MR myelography on the right panel shows severe spinal canal stenosis at the lumbar disc levels. This is a female in her 30s with achondroplasia. After decompression of her lumbar spine, CT was performed due to suspicion of exacerbation of the ligamentum flavum. In the sagittal reconstruction, there is vertebral arch shortening from L3 to L5. Bilateral laminar thickening is also seen on the L4 level horizontal image. Left-sided predominant ligamentum flavum thickening is observed at the TH12/L1 level. Also, the sacrum is positioned horizontally on sagittally reconstructed image. Moving on to the congenital anomalies of the spine. Spina bifida. Spina bifida is a term that indicates failure or fusion of the posterior bony component of the spine or vertebral arch to spinous process. But clinically, it is used almost synonymously with spinal dysraphism. Spine or spinal cord malunions are congenital abnormalities of the spine or spinal cord and include all diseases in which mesenchymal, bony, or neural tissue has midline malunions. There are several classifications of spina bifida and spinal malunions, and the names of the individual disease included in these are confusing. Spinal malunions are divided into open or closed. Rossi, Tottori, Donati clinical neuroradiological classification is widely utilized. This is a 2-year-old boy with lipomyelonmeningocele. On CT, the fifth lumbar vertebra, part of the vertebral arch of the sacrum, and the spinous process are missing. A mass with fat density in the dural sac is found at the sacral level on the caudal side of the lower spinal cord. On MRI, a lipoma was found in the spinal canal below the lower part of S2, broadly in contact with the caudal end of the spinal cord at the sacral level, and continued to the subcutaneous lipoma through the sacral defect. T1 weighted and T2 weighted images show a low-intensity cord-like structure continuing from the lower end of the spinal cord and running inside the above-mentioned lipoma. It is thought to be a thick and short terminal filament. The lower end of the spinal cord is at the S2 level, where the spinal cord is tethered. Near the lower end of the spinal cord, T1 weighted sagittal images show vertically elongated low intensity near the center of the spinal cord, and T2 weighted images show a wider range of high intensity. There is an enlargement of the central canal or possibly syringomyelia. Lipofale syndrome is a disease in which 2 to all cervical vertebrae are fused, and the cause is unknown. The incidence is 1 in 40,000 live births, and it is thought to be due to developmental abnormalities at 3 to 8 weeks of gestation. Klippel-Feil syndrome with cervical spine fusion is clinically diagnosed by 3 characteristics. Number 1, short neck and resulting facial asymmetry. Number 2, low hairline in the upper part. And number 3, limitation of neck movement, but only half of the cases meet these criteria. It is also pointed out that the frequency of occurrence is underestimated. This is a male in his 40s with Klippel-Feil syndrome. This patient was rear-ended in the driver's seat of a car while stopped, and developed neck pain and arm numbness, and an MRI was taken for detailed examination. On the left side, a T1 weighted sagittal image shows a wasp waist sign or shortening of the antero-posterior diameter of the vertebral body at C45, and T1 weighted sagittal image on the right shows a fusion of the right side of the C4/5 vertebral body. A diagnosis of Klippel-Feil syndrome was incidentally made. Sprengel's deformity. Sprengel's deformity is usually associated with other congenital anomalies such as spina bifida, kyphoscoliosis deformity, and torticollis. The omovertebral bar, a fibrous, cartilaginous, and/or bony structure between the scapula and cervical spine, is often seen. It is also commonly associated with local muscle hypoplasia or atrophy, and these associated features can lead to further malformation of the shoulder and limitation of shoulder motion. Here is Legal's X-ray classification for Sprengel's deformity. Grade 1 medial condyle of the scapula is located between the second and fourth thoracic transverse processes. Grade 2 medial condyle of the scapula is located between the fifth cervical and second thoracic transverse processes. And grade 3 medial condyle of the scapula is located above the intertransverse processes of the fifth cervical vertebra. Here is a 4-year-old boy with Sprengel deformity, grade 2. Medial condyle of the scapula is located between the fifth cervical and the second thoracic transverse processes. Next is anterior sacral meningocele. Meningocele is a pathological condition in which the dura mater and arachnoid protrude outside the spinal canal in a cyst-like manner through the spinal defect. Anterior sacral meningocele is a condition in which a cyst filled with the cerebrospinal fluid protrudes in front of the sacrum due to focal hypoplasia or defect in the ventral sacrum, presenting with spinal cord tethering. Anterior sacral meningocele is often associated with the triad of sacral malformation, hindgut anomaly, and presacral mass known as Currarino syndrome. This is a female in her 20s with anterior sacral meningocele. Fat surface T1 weighted sagittal image on the left side shows an anterior sacral bony defect with a smooth-walled 10 cm cystic mass contiguous with an intraspinal dural sac. T1 weighted images show signals similar to those of cerebrospinal fluid on the right side. On T2 weighted sagittal and T2 weighted horizontal images, there is a relatively low intensity portion inside which is considered to be an artifact due to pulsation of cerebrospinal fluid. This patient also had a history of surgery for rectal anal malformation which was considered consistent with Currarino syndrome. Caudal regression syndrome is a rare congenital malformation of the vertebral column, spinal cord, and lower limbs secondary to cascading effects of abnormal castration before the fourth week of fetal development. Pathogenesis is suspected to be rooted in an interplay between genetic predisposition and environmental factors, resulting in a spectrum of phenotypic expression stemming from disturbances in either primary or secondary neurulation, although the mechanism remains poorly understood. This is a 4-year-old boy with caudal regression syndrome type 2. CT images show pubic symphysis separation. The sacrum is small and hypoplastic. Below the level of TH12, the vertebral arches are asymmetrical, indicating spinal dysplasia. Spina bifida is also seen. On MRI, the lower edge of the dural sac is present at the S1 level. The lower end of the spinal cord is flattened and present at the L4 level. From the L2/3 to the lower end of the dural sac, there is a lipoma. Spinal cord lipoma and terminal thread lipoma, from the dorsal side of the spinal cord to the terminal filum, and the spinal cord is tethered. This is the final slide. Diseases touched upon in this talk are listed again. Thanks a lot for your kind attention.
Thank you, Professor Tamatsu, for the informative lecture. And for all participants who wish to ask questions to Professor Tamatsu, again, I remind you to directly type your question in the chat box, and Professor Tamatsu will answer your question. Dear colleagues, as the last lecture from Professor Tamatsu Kamishima ended the plenary session, now allow our supporting partner to give their presentation. Please welcome the representative from Siemens Healthineers, Ahmad Subarkah, then followed by the presentation from Philips Mr. Michel Perkovic. But first, to Mr. Ahmad Subarkah, the time is yours.
Shalom, Om Swastiastu, Namo Buddhaya, Salam Kebajikan. Yang saya hormati kepada segenap pengurus Perkumpulan Subspesialis Radiologi Muskuloskeletal Indonesia, yang saya hormati Panitia PIT Perami tahun 2022, yang saya hormati para pembicara dan segenap peserta PIT Perami tahun 2022. Perkenalkan, nama saya Ahmad Subarkah. Saya adalah aplikasi spesialis ultrasound dari Siemens Healthineers Indonesia. Pada kesempatan yang baik ini, izinkan saya untuk sharing mengenai update teknologi imaging ultrasound untuk MSK. Baik, akan saya share screen. Tema yang akan saya sampaikan pada kesempatan kali ini yaitu see more, know more, and do more. Yang menjadi latar belakang dari tema kali ini yaitu menurut data WHO ada 1,7 miliar orang yang mengalami permasalahan yang berkaitan dengan muskuloskeletal, dan hal ini akan terus naik ya, akan terus increase number dari populasi dan juga dari kondisi yang berhubungan dengan muskuloskeletal. Dan hal ini menjadi tantangan tersendiri untuk imaging, terutama untuk diagnostik imaging, karena diperlukan modalitas imaging yang tepat dan reliable yang bisa diandalkan. Mungkin Bapak Ibu dokter semua sudah bisa mengetahui bahwa banyak sekali benefit dari muskuloskeletal ultrasound, dari modalitas ultrasound yang digunakan untuk diagnostik muskuloskeletal ya, antara lain yang mudah digunakan, low cost, juga lebih murah dibandingkan dengan modalitas lain ya, serta bisa didapatkan hasil yang real time. Dari kami dari Siemens selalu berinovasi mengenai desain maupun mengenai teknologi yang akan memberikan kemudahan kepada pengguna, pada para dokter, dan di sini kami akan memperkenalkan line up terbaru dari platform ultrasound Siemens Healthineers, yaitu dari Akuson Skoya yang merupakan high-end, tipe high-end kami, kemudian ada Akuson Redwood, tipe menengah, dan Akuson Juniper, ya, tipe high performance. Kemudian ada Akuson P500 yang merupakan unit sistem portable dari Siemens Healthineers. Dan kebutuhan penggunaannya akan bisa disesuaikan dengan kebutuhan Bapak Ibu ataupun user sekalian ya. Karena bisa disesuaikan dengan apakah memerlukan fitur-fitur yang advance ataupun diperlukan alat yang portable yang bisa menunjang untuk pemeriksaan yang lebih bisa movable atau bisa dipindah-pindahkan. Baik, untuk yang pertama mengenai see more, tentu saja dari Siemens Healthineers mengembangkan teknologi transducer yang didedikasikan untuk muskuloskeletal. Yang pertama ada transducer terbaru dari kami yang ya, L4 sampai 15 MHz cylinder transducer, di mana dynamic range-nya bisa ditingkatkan hingga 18 decibel, sehingga akan meningkatkan image clarity dan penetrasinya. Nah, ini contoh yang di sebelah kanan gambar, yaitu gambar dari supraspinatus tendon. Kemudian transducer yang selanjutnya yang mungkin Bapak Ibu sudah familiar ya, bagi Bapak Ibu praktisi muskuloskeletal, tentu saja transducer hockey stick di frekuensi 6 sampai 18, dan di alat kami juga sudah mendukung teknologi in-focus coherent image formation, di mana gambaran dari near field to far field akan uniform. Dan di sini di gambar contoh kami dual image demonstrate dari region tenar dengan fluid ya yang terlihat di gambar sebelah kiri ya. Kemudian untuk yang selanjutnya ada transducer spesial juga untuk muskuloskeletal yaitu 18L6 high frequency linear transducer. Ya, ini bisa dari desainnya sendiri Bapak Ibu mungkin bisa membayangkan ya betapa mudahnya nanti untuk digunakan untuk dilakukan scanning dan mungkin tangan Bapak Ibu akan tidak cepat capek ya dengan menggunakan transducer ini. Dan ini contohnya, contoh gambarannya yaitu sagittal view dari bicep tendon. Nah ini yang tadi saya sampaikan bahwa in-focus imaging teknologi akan memvisualisasikan gambaran yang uniform, yang seragam dari near field to far field. Kemudian berikut ini ada beberapa contoh dari gambaran ultrasound akuson Sequoia dan akuson Redwood ya. Gambar di sebelah kiri layar merupakan gambaran supraspinatus transversal dan yang di sebelah kanan layar yaitu bicep tendon transversal. Yang selanjutnya ada dari akuson Sequoia juga menggunakan hockey stick, interscalene. Kemudian yang di sebelah kanan ada gambaran dari akuson juniper hockey stick dan menggunakan HD zoom ya. Dan di situ gambaran flexor. Untuk selanjutnya ini adalah contoh gambaran dari akuson juniper di mana menggunakan fitur HD zoom yang apabila kita perbesar gambarnya dan high definition zoom ini tidak akan mengurangi frame rate sehingga gambaran yang dihasilkan juga akan tetap memberikan resolusi spasial yang jelas. Kemudian untuk akuson Sequoia-nya yang di sebelah kanan layar Bapak Ibu ya, di situ ada gambaran color Doppler pada no liquid flow ya. Jadi di situ cukup jelas gambaran color Doppler-nya karena di alat kami sudah menggunakan auto flash artifact suppression di mana teknologi color Doppler-nya sudah bisa mengeliminasi gambaran artefak pada pergerakan. Baik, untuk selanjutnya kita lanjutkan untuk no more di mana fitur-fitur advance apa yang terdapat di line up ultrasound kami, terutama di akuson Sequoia dan akuson Redwood, yaitu ada 2D shear wave elastography, kemudian ada panoramic view dan fusion imaging. Bapak Ibu bisa lihat di sini adalah gambaran phantom dari elastogram ya pada akuson Sequoia 18L6 di mana di situ akan terlihat jelas bordernya dan memperlihatkan color map-nya yang sangat sensitif. Kemudian di sebelah kanan sebelah kanan layar Bapak Ibu di situ ada gambaran 2D shear wave elastography dengan pengukuran elastisitinya. Seperti yang Bapak Ibu mungkin sudah ketahui ya bahwa elastografi teknologinya sangat berkembang bahkan pada bidang muskuloskeletal imaging ya. Jadi jurnal ada banyak sekali yang meneliti mengenai 2D shear wave elastography pada muskuloskeletal ya. Karena memang bisa digunakan untuk mengetahui bagaimana stiffness dari tisu tersebut, kemudian bisa mengetahui dari injury ataupun repair evaluation maupun bisa mengetahui dari stiffness dan ekogenitas dari struktur tersebut. Sehingga hal ini, elastografi ini menjadi kebutuhan yang bisa menunjang untuk meningkatkan confidence dari diagnostik dari muskuloskeletal tersebut itu sendiri. Ya ini contoh dari gambaran 2D shear wave elastography pada akuson Sequoia. Ya, jadi di samping kita bisa mendapatkan gambaran secara kualitatif yaitu dari color code map-nya di mana warna biru dan merah ini akan menandakan tingkat dari stiffness dari jaringan tersebut. Di samping itu juga secara kuantitatif kita bisa mendapatkan hasil yang secara instan ya gambaran elastisitas maupun gambaran velositas dari gambaran objek muskuloskeletal tersebut. Ya, di samping itu tentu saja di alat kami, di sistem ultrasound kami sudah bisa untuk digunakan sebagai panoramic imaging ya. Apabila Bapak Ibu dokter ingin mengcapture objek yang panjang, jadi bisa diaktifkan panoramic imaging. Ini contohnya pada calf muscle pada transducer 10L4. Kemudian ini ada contoh dari akuson redwood 18L6 panoramic patellar tendon. Jadi kita juga bisa melihat secara utuh per bagiannya, jadi tidak terlalu kecil gitu ya. Kita bisa zoom juga di bagian tertentu tanpa mengurangi resolusi. Baik, kita selanjutnya akan saya sampaikan yaitu fusion imaging. Mungkin Bapak Ibu ada yang sudah mengetahui, mungkin ada sebagian yang belum ya. Jadi fusion imaging ini sendiri adalah penggabungan imaging dari CT maupun MRI dengan real time ultrasound. Ini tujuannya ada banyak ya Bapak Ibu ya. Ini saya langsung ke tujuannya yaitu clinical solution dari musculoskeletalnya, yaitu diagnostik dan therapeutic assessment untuk shoulder, untuk deep pelvic nerve maupun hip procedures. Samping itu juga bisa untuk guided injection. Jadi apabila Bapak Ibu melakukan injeksi pada organ-organ tertentu ya, jadi akan lebih tepat apabila digunakan gambaran dari MRI yang secara anatomikal presisi dengan digabungkan dengan real time ultrasound. Di samping itu juga bisa digunakan untuk soft tissue biopsy guidance. Ya. Ya, kita akan lanjut ke bagian selanjutnya yaitu mengenai do more. Yaitu di teknologi akuson Skoya sudah bisa gestar detecting transducer, di mana apabila Bapak Ibu mau mengaktifkan transducer, tinggal diketuk 2 kali pada transducer tersebut dan transducer yang dipilih akan aktif secara otomatis tanpa perlu mengubah di sistem ya. Jadi ini akan mempermudah dan mempercepat pemeriksaan Bapak Ibu. Samping itu juga kemudahan yang lain tanpa perlu banyak mengatur frekuensi, kemudian mengatur gain dan sebagainya, kita memiliki ultra out real time quad display. Jadi ada 4 pilihan gambar di situ secara real time. Bapak Ibu bisa langsung memilih di touchscreen-nya ya, gambaran mana yang paling sesuai begitu ya, dari tingkat kekasaran dan sebagainya. Jadi tanpa perlu banyak mengubah tombol, ini sangat memudahkan Bapak Ibu untuk melakukan pemeriksaan. Kemudian ini ada video penutup dari kami. Izinkan saya untuk memutarnya ya. Maaf, suaranya tidak terdengar ini. Jadi di sini di video ini merupakan proses dari produksi alat ultrasound kami, di mana setiap bagiannya sudah melalui proses quality assurance dan quality control yang sangat ketat, sehingga produk yang dihasilkan pun akan bisa diandalkan, sangat bisa diandalkan. Dan ini adalah yang pada layar ini adalah produk-produk kami. Ada akuson Skoya, akuson redwood, akuson juniper, akuson freestyle yang merupakan ultrasound wireless pertama di dunia waktu itu ya, tahun 2012. Kemudian ada akuson P500 juga yang merupakan portable system yang bisa digunakan untuk pemeriksaan-pemeriksaan muskuloskeletal yang mudah dibawa. Jadi apabila Bapak Ibu masih memiliki pertanyaan, mungkin bisa menghubungi saya ataupun representatif Siemens di daerah Bapak Ibu semuanya. Ya. Baik, mungkin demikian yang bisa saya sampaikan pada kesempatan kali ini. Mohon maaf apabila ada kesalahan, ada salah-salah kata, dan terima kasih banyak atas perhatian dan dari Bapak Ibu semua. Saya ucapkan terima kasih. Saya akhiri. Assalamualaikum warahmatullahi wabarakatuh.
Yeah, thank you for Mr. Ahmad Subarkah. Due to the video, we don't have any sound in your video, so you can put your video again in your exhibition booth. Okay, participant, next we will have the presentation from Philips. Mr. Michel Perkovic, the time is yours.
Hello, my name is Michelle Perkovic and I'm the Clinical Business Marketing Manager for Philips Ultrasound, and today I'll be talking to you about the MSK solution on the Epic Elite Premium Ultrasound System. The Epic Elite Ultrasound System is a universal platform, so it allows you to scan all clinical applications, starting even at cardiac, abdominal, breast imaging, gynecology, vascular, and obstetric imaging, but today we'll be focusing on the musculoskeletal application. Across all of our clinical areas, we have built some ultrasound solutions, and within those solutions, including the small parts MSK solution, we talk about tools that are the fundamental tools that you need to make your clinical diagnosis, all the way up to those advanced tools. So let's dive into the MSK solution. To achieve exceptional resolution, you need an exceptional beamformer, and that is our N-Sight beamforming technology. We added two major components of hardware to the Epic Elite Ultrasound System to really boost the performance of our beamformer, and that really gave us 40% boost in image resolution and throughput. So faster frame rates, better image uniformity, right down to a pixel level. And as we introduced high frequency transducers, we didn't need to compromise on penetration. X-Res Pro is our next generation or third generation of image processing, elevating tissue definition. So what it does is it reduces known artifacts. So if it detects artifacts, it subtracts them. It gives you better clarity of textures and interfaces of tissue, better border delineation, again, overall improving your diagnostic confidence. Here's some examples of X-rays imaging in action across a range of clinical applications, essentially giving you that clarity that we expect, allowing you to give you, that image the aesthetic that you prefer, from a very dotty image all the way up to a more smoothed image if that's your preference. Here's an example of X-Res Pro and how it was added to our L15-7 hockey stick transducer, and I think you can see clearly how that enhances the resolution here of the anatomy, and in this case the finger tendon in transverse. That hockey stick transducer is a really fantastic transducer. It's one of our workhorse MSK probes. Its small footprint allows you to access those tight to navigate areas, and very useful in the interventional setting. The L18-5, again with X-Res Pro, is an exceptional transducer delivering high resolution imaging in superficial MSK. And the L12-5 with X-Res Pro gives you some great clarity right down to those deeper MSK structures. But what if you could combine the L18-5 and the L12-5 into one transducer? Well, we've done that with Epic Elite and the EL18-4 ultra broadband transducer. It has some advanced technologies such as microflow imaging, a full solution elastography offering, and some biopsy tools. And it's also a pure wave transducer, so it's very efficient, sending and receiving the signal, giving you better 2D image resolution, 85% more efficiency, and also clarity with your Doppler sensitivity too. It's a multi-row array transducer, the EL18-4, and it allows us to electronically focus the elevation plane. When we have a thinner elevation plane, we have better image resolution, And the benefit of this is that we can drive frequencies from 2 all the way up to 22 megahertz with the one transducer. Now, this transducer can be focused, like we said, and we can drive the penetration simply by moving the focal zone. So we move the focal zone down, we engage all of the elements, so we don't just get nice near field resolution, but we get far field resolution all the way down to 14 centimeters. And we have 3 dedicated MSK presets with this transducer: MSK superficial here with the wrist, MSK gen or general here with the shoulder, and MSK deep, which is very useful for that hip imaging. We also introduced a new SuperFic preset, really tailored to the needs of the Australian MSK customer. They have a need to see that resolution of the fine textures of the tissues all the way from the skin, fat layer, muscle layer, tendon layer, bone layer. So you can see that very nicely with this new SuperFic setting. Here again, some examples of shoulder imaging. And it added the EL18 for a new feature called trapezoid imaging. So what we can now see is very nice resolution in the lateral margins when we have that one-touch trapezoid and giving us that extended field of view. If you need more extension of field of view, you can also use our panoramic imaging tool, which images up to 1 meter in length. We made sure that we didn't compromise on our colour Doppler imaging as well. We enhanced our colour Doppler imaging here with the Achilles tendon example. And we added an additional layer of sensitivity with our colour Doppler called microflow imaging. Remarkable sensitivity and detail in those low, slow, weak flowing blood vessels. We can actually see now with microflow imaging high definition, which is already our second generation of microflow imaging, twice the sensitivity and resolution of standard microflow. And I'll show you some examples. This is microflow imaging on that same Achilles tendon. You can appreciate those finer structures, greater sensitivity and resolution. Here is some examples in the finger and here in the wrist. And now when we look at a comparison of microflow imaging in the common extensor tendon, we can see a little bit of flow, and then when we turn on microflow imaging high definition, we get twice the sensitivity and twice the resolution. So you can see how helpful this is in the MSK setting. We've got a lot of literature on microflow imaging and MSK in general, so you feel free to ask one of us if you're interested in reading that literature. We have advanced technologies such as shear wave elastography, allowing you to quantitatively measure muscle and tendon stiffness. And in intervention, you need to have good clarity of your needle. Here you can see the needle with the reverberation artifact nice and clearly being used to inject a subdeltoid bursa. And here we have that next level of support, if you need it, with a needle visualization tool where you can actually steer the beam perpendicular to your needle to get that nice bright reflection. We have the HD Max display monitor, which is very useful in intervention, looking at fine structures in MSK, because it allows us to use max view high definition imaging. So you can actually use full screen imaging to really bring up those fine structures, giving you 30% more viewing area, better resolution, especially when you're targeting tiny, tiny structures. And we have some integrated time-saving tools such as Smart Exam, which helps you guide yourself through an MSK exam. We can set that up for you. We also have the iScan one-touch optimization button for TGC and gain, and auto scan. If you like using iScan all the time, you can turn on your auto scan button. Now, if you want to really take your imaging to a very advanced level, you can use our world's first linear X matrix transducer, the XL143. Here you can actually see anatomy in 2 planes live at once. Here's an example of that in MSK imaging. On the left, the proximal biceps tendon, and then the distal biceps tendon. So you can really just scroll through the image using your trackball without having to rotate your transducer. And both of these images are live for you. Very useful in biopsy work, but you can also do 3D imaging. We have many doctors around the world using this technology to help them get that surgeon's view. Here's an example of a supraspinatus tendon that's been torn. Dr. Klinenberg is sharing this case at ECR. So he's using these advanced technologies. And if you're not familiar with 3D, that's fine. We've got some auto view technology here where you can press the button on the system and it automatically takes you into that 3-dimensional MSK image. Finally, Philips Education, we're always here to help you with education. We've got ongoing education and tutorials that we can give you. We have live webinars and on-demand webinars that you can watch at your leisure. So we can share that website with you. And currently we've got 2 MSK webinars that are on demand and available for you in elbow, wrist and hand pathology and shoulder pathology. Collaboration Live is one thing I want to share with you, and that is it's a tool that can be useful for the novice MSK sonographer if you need support from an expert. So you can call in an expert, they can have a look at what you're doing live, and they can share over-the-shoulder tips as if they were in the room with you. And we did that live in Australia recently with Dr. Cresswell, who was in Canada, and in Australia he was sharing tips with us at a conference on how he does his shoulder scanning. So that's my quick overview of our MSK solution. Thank you for listening to my presentation, and feel free to reach out to me or my colleagues if you have any questions. Thank you.
Yeah, thank you for Ms. Michelle Perkovic for nice presentation. And dear participant, the plenary session and sponsor presentation is now completed. So please enter Hall A or Hall B to join parallel meetings. Hall A will conduct general topic of pediatric MSK with me as moderator, and Hall B with topic of bone tumor with Dr. Paulus Raharjo as moderator. See you in the parallel session. In pediatric musculoskeletal. So we have 4 distinguished speakers in this session, and let's get started. Yeah, please welcome our first speaker, Dr. Mira Tajanovic. She is the Emerita Professor Medical Imaging and Orthopedic Surgery, University of Arizona. And Professor Mira Tajanovic will give us lecture about imaging and treatment of the discoid meniscus. Dr. Mira Tajanovic, the time is yours.
I'm Dr. Tajanovic from University of New Mexico and University of Arizona. In next 20 minutes or so, I will talk about imaging and treatment of the discoid meniscus. I prepared this talk in conjunction with my colleague from orthopedic department from University of New Mexico, Dr. Christopher Schultz. We have no relevant disclosures. The leading objectives are to describe definition, incidence, and clinical presentation of the discoid meniscus, discuss various classifications of the discoid menisci, show radiographic and magnetic resonance imaging findings of the discoid menisci, and discuss treatment options of the discoid menisci. As you know, the menisci have semilunar shape. The medial meniscus has larger posterior than anterior horns, and the lateral meniscus has relatively equal anterior and posterior horns, and both menisci have anterior and posterior root attachments. As you know, on the sagittal MR images, normal menisci have triangular shape and low signal intensity on all pulse sequences. By increasing and deepening the contact surface area, the menisci provide dynamic support and act as stabilizers and shock absorbers of the knee joint, protecting the articular cartilage while also contributing to joint proprioception and lubrication. As you know, there are various types of meniscal tears which can affect normal and also discoid menisci. The discoid meniscus is congenital developmental variant and looks like a thickened disc-like morphology with central hypertrophy, resulting in increased width of the meniscal body, leading to lack of the characteristic C-shaped configuration. Discoid meniscus may lack normal posterior meniscocapsular and ligamentous attachments and covers broad spectrum of meniscal morphology and stability. The lateral discoid menisci are much more common than medial, and they have incidence of 3 to 5% in USA, 0.4% in Scandinavia, and increased incidence in Asian population, especially in Japanese population, with reported incidence of 13 to 16%. The medial discoid menisci are rare, with reported incidence of 0.06 to 0.3%. The discoid lateral meniscus was first described by Young in 1889 in cadaveric study, while discoid medial meniscus was first described by Watson-Jones in 1930. The exact inheritance pattern has not been identified. Many patients are asymptomatic, and discoid menisci may be incidentally diagnosed, or they can be diagnosed when become symptomatic with a tear. Individuals with discoid meniscus in one knee have increased incidence of a contralateral discoid meniscus, reported to be 15 to 25%, but is more common in Asian population and has male predominance. There is reported decreased density of extracellular matrix, disorganization of the collagen fibers, absent or reduced cellular components, and variably reduced vascularity in discoid menisci. Stable, intact discoid lateral menisci typically are asymptomatic and have mild symptoms such as clicking. They are more prone to tears and instability, commonly presenting with pain, snapping, limited extension, locking, swelling, and anterolateral bulging on full flexion. Various radiographic measurements and ratios are proposed in literature with debatable clinical relevance. These include, but are not limited to, lateral tibial spine height, lateral joint space height, and lateral tibial plateau obliquity. In this particular case, you can see widening of the lateral joint space compartment in a patient with discoid lateral meniscus and some hypoplasia of the lateral femoral condyle. Watanabe classification was introduced in 1978 and is widely used. This includes type 1 or complete discoid lateral meniscus, which covers the entire tibial plateau and has normal posterior capsular attachment. Type 2 or incomplete discoid meniscus has semilunar morphology and covers up to 80% of the lateral tibial plateau surface and has normal posterior capsular attachment. In our department, we use 15 millimeters cut-off for diagnosis of discoid meniscus with the meniscal width of 15 millimeters or more on the mid-coronal cut. But although the cutoff of 13 and 14 millimeters were also reported. Commonly used MRI criteria for the diagnosis of the discoid lateral meniscus is 3 or more consecutive 5 millimeter sagittal slices or 4 or more consecutive 4 millimeter sagittal slices demonstrating continuity of the anterior and posterior horns, or so-called bow tie appearance. The Vrisberg type of the discoid meniscus is rare and is arthroscopically proven in less than 2% of cases. May have discoid morphology, but more commonly normal morphology. Typically, there is a slightly thickened posterior horn, and this type of discoid meniscus lacks meniscocapsular fascicles and meniscotibial coronary ligament. The meniscofemoral ligament of Vrisberg is a solitary stabilizer of the posterior horn and typically stick, not really in this patient. The ring-shaped discoid meniscus is rare, and I have never seen in my practice. These are the images from literature showing connection between the anterior and posterior roots in the intercondylar notch, which can replicate the appearance of a discoid meniscal fragment, bucket handle tear. So the other reported MRI criteria include ratio of the lateral meniscus to tibial width, dividing the minimum width of the meniscal body by the width of the tibial plateau. The ratio between minimum width of the lateral and medial menisci. As you can see over here on these images from the literature showing the measurements of the width of the discoid lateral meniscus and tibial plateau. Discoid menisci in children are also described as slab type with rounded free edge and wedge type with tapered free edge. These images are from the nice paper from skeletal radiology, and they really have a nice review of discoid meniscus. The other classification proposed in 2004 by Klingele defined the meniscal peripheral rim is defined by meniscal peripheral rim stability, stable versus unstable, meniscal morphology, discoid versus non-discoid, and the presence or absence of tear, present or absent. Classification from 2009 by Anne et al. Is MRI-based to assist surgical decision-making for patients less than 16 years old, which included 4 categories according to the presence and direction of meniscal shift secondary to meniscal tears. This is the proposed Young classification of discoid menisci based on stability, morphology, presence of tear and tear location, and predicts surgical repair. So as you can see over here, the discoid menisci are divided into the stable and unstable, and each category in incomplete and complete discoid menisci. And in each subcategory, this is further classified to no tear, central tear, or central tear with peripheral extension. The discoid menisci have increased incidence of tears up to 30-fold compared to the normal menisci. Horizontal cleavage tears are common in young children, but complex tears occur in all age groups but are more common in adults. Displacement of torn meniscal segments is reported in 72% of discoid lateral menisci undergoing arthroscopic treatment, and articular cartilage lesions are commonly associated. The reported accuracy of MRI for diagnosis of discoid lateral menisci is variable. Yilgor et al. In 2014 found MRI to be 100% specific and 97.8% sensitive for determining the presence or absence of a tear with a negative predictive value of 85.7% and positive predictive value of 100%. Regarding the tear type, specificities were 80% for horizontal cleavage tear, which was the highest, and the lowest specificity was 14.3% for longitudinal tears, whereas the sensitivities ranged from 100% for longitudinal tears to 66.7% for horizontal cleavage tears. Here is a 70-year-old patient with incomplete discoid lateral meniscus and small radial tear, as you can see over here at the free edge, treated with partial lateral meniscectomy. The same tear you can see over here on the axial and again on sagittal images. Peripheral instability of the discoid lateral meniscus may be the result of congenital absence or post-traumatic tearing or stretching of the peripheral meniscal attachments, or it may occur when a large enough tear causes the meniscal shift or causes the meniscal fragment to be displaced into the joint. The pseudobucket handle tear occurs when the discoid lateral meniscus is displaced centrally into the intercondylar notch in the absence of a meniscal tear due to peripheral rim instability. Stability is assessed arthroscopically by probing the meniscus and its attachments and by attempting to shift or revert the meniscus. The sites of peripheral instability are variable, can occur with any type of discoid meniscus, particularly with peripheral tear extension. Here is a 14-year-old female with complex, unstable discoid lateral meniscus treated with socialization and repair. You can see here on these images degeneration of the discoid lateral meniscus with marked hypertrophy of the posterior horn, and you can see its central radial tear on the sagittal image. The discoid medial meniscus is rare, as previously mentioned, and classification is different, including type 1, which is normal, type 2, deficient tibial insertion of the anterior horn with continuity of the anterior horn and intermeniscal ligament over the anterior cruciate ligament, and type 3, anterior horn continuity with the anterior cruciate ligament. Here are the images of the 15-year-old female with discoid medial meniscus and congenital absence of the anterior cruciate ligament. You can see here the hypertrophy of the medial meniscus with degeneration of the posterior horn. And on these sagittal images, you can see extension of the hypertrophic medial meniscus into the intercondylar notch and absence of the anterior cruciate ligament. The patient was treated with anterior cruciate ligament reconstruction using Hemsing allograft and partial medial meniscectomy. Incidentally diagnosed asymptomatic discoid lateral menisci require no treatment. Surgical treatment for symptomatic discoid lateral meniscus includes partial meniscectomy or socialization. Socialization is trimming of the central free edge of the discoid meniscus, resulting in meniscal dimensions similar to those of a normal meniscus, with a 6 to 8 millimeter peripheral meniscal rim. Any remaining meniscal tears can be repaired where possible. Absent or unstable torn peripheral and capsule attachments can be sutured. Other less commonly described techniques for surgical treatment of discoid lateral meniscus include single leaf partial meniscectomy for extensive horizontal tear, meniscoplasty, meniscopexy, and meniscal allografts. So here is the treatment algorithm for the discoid menisci. Here is a patient of mine, 37-year-old male with unstable complete discoid lateral meniscus, treated with arthroscopically assisted partial lateral meniscectomy with socialization of discoid meniscus. You can see over here myocarpatrophy and degeneration of the discoid lateral meniscus with tearing, and also this is seen on the coronal images. And I will now show video of arthroscopic treatment.
This presentation, we are highlighting the arthroscopic discoid meniscus lateral HallA superior probes used to examine lateral meniscus and extend the discoid by tears seen lateral. As you can see, stable section socialization stable. Now see
And a couple take-home points. Discoid menisci involve a spectrum of meniscal morphology and stability. They are more prone to trauma compared to non-discoid menisci. Many of these are asymptomatic. Discoid menisci with tears and instability are frequently imaged. It is important to recognize the morphology and tear pattern of the discoid meniscus, meniscal shift, and different peripheral attachments to assist with arthroscopic treatment planning. And that was it, and I thank you for your attention, and I'll be happy to answer any questions.
Thank you, Professor Mira Tarjanovic, for your very insightful lecture. And the second speaker is Dr. Srikant Narayana Swamy, currently Senior Consultant Radiologist at Sakra World Hospital, Bangalore, India. And Dr. Srikant Narayana Swamy will deliver topic of imaging in adolescent anterior knee pain. Dr. Srikant Narayana Swamy, the time is yours.
Good morning, everyone. For the next 20 minutes, I will be talking about imaging in adolescent anterior knee pain. As we all know, anterior knee pain is one of the most common conditions that patients present with, and there is quite a complex biomechanical interaction that happens at the patellofemoral joint purely because there are various structures which comes into play at this particular joint. There are multiple causes of anterior knee pain, and for the purposes of this talk, I will be only concentrating on the MR imaging, as we do not have enough time to look at other imaging modalities. You can broadly classify the anterior knee pain based on either it's related to a trauma, or most commonly it's your chronic overuse injuries that patients usually presents with. And very rarely you will come across your inflammatory or tumor pathology. Likewise, if you look at the structures which are involved in causing this anterior knee pain, it can either come from your bones or your tendons, ligaments, or plica, or it could be coming from the fat pad or cartilage, or it could simply be joint-based, or could be coming from your soft tissues. So let's look at one by one. If you look at your post-traumatic contusions, this is a kid who actually fell directly onto the patella, came in with an acute knee pain. Initial x-rays were inconclusive and was reported as normal. As he continued to have pain, he ended up having an MRI, which showed a diffuse bony edema in the patella. And if you look carefully, the fat suppressed sequences demonstrates a subtle low signal line, perhaps representing an undisplaced fracture. This is another example of a subchondral fracture that you're seeing in the lateral femoral condyle. And this is not your deepening of the condylopetallar circus that you see with ACL tears. This is just a straightforward subchondral fracture following an injury. Or it can be quite obvious, as in this case, wherein there is a displaced proximal tibial fracture with extension into the growth plate. You can see the displacement anteriorly. Bipartite patella is quite a common thing that we tend to come across on X-rays and MRI. Usually it's a normal anatomical variant and does not cause any pain. However, very rarely I've seen some amount of edema or cystic changes around the synchondrosis and can present with anterior knee pain. This is a classical sort of a bony contusion pattern that you're seeing in the medial pole of the patella and in the lateral femoral condyle, indicative of a classical patellar dislocation. And whenever you see this bony contusion pattern, you do have to comment on the integrity of MPFL, whether it is completely torn or whether it's partially torn. And more importantly, most of the times we tend to see that the cartilage along with a piece of bone gets peeling off during this dislocation episode. So you really need to look out for any loose osteocartilaginous fragment in cases of patellar dislocation. Moving on to the tendons. This is your quadriceps tendon and patellar tendon. These are the two tendons which can contribute to the anterior knee pain. Any issues related to that can present in anterior knee pain. And this is a case of a distal quadriceps tendinosis, wherein you can see the edema within the distal quadriceps, and there are some insertional enthesophytes. And this is a classical case of quads tendinosis. Presence with anterior knee pain. It could be related to an underlying biomechanical issues, probably related to poor quads or glute strength, or could be related to poor hip mobility. So important for us to address those biomechanical issues. This is another case, young chap coming in with a patellar pain, and MR showed this patellar tendinosis, wherein you have this sort of an edema just around the mid portion of the patellar tendon, and also with a partial tear of the deeper fibers of the patellar tendon. This guy responded well to the conservative management. Moving on to a different spectrum, which is related to your traction related pathologies. And this is a case of an Osgood-Schlatt's disease. You can see that due to the constant traction exerted by the patellar tendon, you have this edema within the distal patellar tendon. And you can also see that the tibial tuberosity is fragmented. And there is also some edema deep to the patellar tendon within the Arfas fat pad. Whenever you see this condition, classically happens in adolescent athletes between 11 to 14 years of age group, presents with a pain which is long-standing and gradually reaches a point wherein it becomes quite unbearable. And all that you require is a period of offloading for these kids, and also addressing any underlying biomechanical issues. Very, very rarely they may require a surgical intervention because it's a self-limiting thing and usually resolves on its own. Likewise, the similar pathology, the traction-related event, can happen in the proximal patellar segment. And this is a case of a Sinding-Lawson-Johnson syndrome, wherein you're seeing that there is some amount of edema within the inferior pole of the patella, along with some amount of edema within the proximal patellar tendon, and also deep to the structures within the Arfas fat pad. So these cases especially presents once again with anterior knee pain, chronic condition, and you really need to think of assigning Lawson-Johnson syndrome in the right age group. Unlike this condition, if a kid who is absolutely fine presents with an acute onset of pain following a high impact injury, you really need to be thinking about patellar sleeve avulsion. When you take an X-ray, all that you will see is a sleeve of bone being separated from the inferior pole of the patella. And on MRI, you will not only see the bone which is being peeled off, along with edema in the proximal patellar tendon, but you will also see a larger segment of the cartilage being also, in some of the cases, being peeled off. So it becomes very important for us to make a note of this extent of cartilage separation, which can be occult on the X-rays. Tendon ruptures, not, it's not one of those normal things that you see in adolescent age group. This is a case of a distal quadriceps tear, and another case of a proximal patellar tendon tear. You can see that the tendon is retracted. There are also a few bony fragments indicative of an avulsion fracture. This is another case wherein this kid had multiple episodes of dislocations, had an MPFL reconstruction done. Again, unfortunately, had a twisting injury, came back with an anterior knee pain. The scans showed MPFL re-tear again, almost like a grade 2. There is also some bony edema within one of those pieces of bone that you can beautifully see on the CT. And more importantly, he also had a loose rolled up cartilaginous fragment lying in the suprapatellar recess. So even in a post-surgical context, you do get quite a bit of an injury that can potentially happen. So do look out for these conditions. Moving on to a different spectrum of pathology, which is your fat pad syndromes. And you have an Arfas fat pad, which is your infrapatellar fat pad. And suprapatellar region, you have a fat pad which is sitting deep to the quadriceps tendon, which is your quadriceps fat pad. And the one which is anterior to the femur is your prefemoral fat pad. If you look at the examples, this is a case of an edema in the superolateral aspect of the Arfas fat pad. And this is your classical patellofemoral impingement that you see. And you really need to look out for this, because if you don't look out for this, you might be able to miss it. So whenever you go through on the sagittal sequences, go on to the most lateral aspect. If you see any edema, do think of superolateral, Arfas fat pad impingement. Moving on to the other one, which is your quads fat pad. Here you can see that the quadriceps fat pad is edematous and it is convex inwards, and this is a case of a quads fat pad syndrome. Likewise, here you're seeing a case of a prefemoral fat pad syndrome or edema within the prefemoral fat pad. Whenever you see these things, whether it's Hoffa's fat pad or prefemoral or quads fat pad, you do have to look at what is the contributing factor. It could be due to an abnormal bony anatomy that is there, or it could be related to an underlying biomechanical issue that needs addressing. But it can be debilitating and it can be painful. Moving on to the cartilage, wherein you're seeing this patellofemoral articular cartilage. You do get various spectrum of cartilage degeneration or chondromalacia that you may come across in anterior knee pain. And if you look at it, this is a case of a slight edema that you're seeing in the cartilage with underlying subchondral edema. Here you're seeing a fissuring which is almost extending up to the deeper surface. Here there is a larger fragment of the cartilage fissuring with fraying, and in this case there is a focal cartilage loss. You can classify it, you can grade these chondromalasias. I usually document it and I say, is there an edema? Is there any underlying fissuring? If there is a fissuring, is this a surface fissuring or a deeper fissuring? Is there a cartilage loss? Is it a partial cartilage loss or is it a deeper cartilage loss? I tend to sort of describe it and put it in my report. Likewise, you can also get an osteochondral defect, wherein you're seeing that in this particular case, there is a chip of cartilage along with piece of bone is peeled off from the lateral trochlea. You can also see the fluid tracking between the OCD and the underlying parent bone. Whenever you see this, you should be thinking of straight away an unstable OCD. Whenever I see an osteochondritis dissecans or a OCD, I normally look at, is this a stable fragment or is this an unstable fragment? And depending on that, I tend to sort of, figure out whether we can manage it conservatively or whether this patient requires a surgical management. Whenever I see any of these anterior knee pain pathologies, I usually comment on few things. And one of the things is about patella alta or baja. Here, what I do is I look at the length of the patella tendon, I look at the length of the patella, and this divided by this gives me a measurement. I take it 0.8 to 1.2. Anything more than 1.2 is patella alta. Anything less than 0.8 is patella baja. And that's quite an important measurement for us to give to the orthopedic surgeon. Of course, those measurements can vary depending on where you're measuring and which textbook you're reading. But this is what I tend to follow. And the trochlear dysplasia is another parameter that I tend to always give. Here, I look at the sagittal image first and go on to the midsection of the sagittal image and take a 3 centimeter above the level of knee joint line, and exactly the 3 centimeter above the level of knee joint line on the sagittal image, the corresponding axial cuts I take, and I look at the trochlear depth. If the trochlear depth is less than 3 millimeter, it is indicative of a trochlear dysplasia. If it is more than 3 millimeter, it's a normal thing. Once again, you can classify the trochlear dysplasia depending on varying degrees of the measurements that you see, and also whether it is concave or convex trochlear notch that you're seeing. The other thing is I also look at the sulcus angle. If the sulcus angle is more than 144 degrees, it is indicative of an hypoplasia. Also, you can look at the lateral subluxation, essentially giving you a measurement of how much the patella is laterally subluxed in relation to the femoral condyle. The other important thing that I tend to measure is TTTG distance. You can either have a software, if you have an inbuilt software that gives you this particular measurement. Otherwise, what I do is I go on to the slice wherein it gives me a good sort of a true notch definition. and then I essentially put a line just through that notch, anterior and posterior one. I usually use a paper or something just to define that line for me, and then I scroll down to the level of tibial tuberosity, and then I draw a line from the midpoint of the tibial tuberosity to the line that I have drawn. Make sure that this red line is parallel to the posterior intercondylar line. If the posterior intercondyle is angled slightly differently, even your line needs to be angled. So I take less than 1.5 as normal, more than 2 as abnormal, and anything between 1.5 to 2 as equivocal. Bursitis, you have your superficial prepatellar bursitis. This can be sometimes, if it's mild, can be confused with a prepatellar hematoma. So history of injury is very, very important. This is a case of a deep infrapatellar bursitis, or another case of a moral level lesion, wherein you see the patients do give a classical history of a degloving kind of an injury. And when you do the scans, you will perhaps see some T1 fat signals. Whenever you see that with fluid, then you're always thinking of moral level lesion. Plica syndrome, I report it very occasionally. Until and unless it is significantly thickened or it's torn, I tend not to comment on that. And this is your medial plica syndrome, wherein the medial plica is significantly thickened. This is a case of an injury to the ligamentum mucosum, your infrapatellar plica, wherein it is quite a bit edematous, and there's a loss of definition of those fibers in this particular case, indicative of an injury, or your suprapatellar plica, wherein the plica is thickened and it is partially torn as well. You may also come across the other conditions such as tumors and inflammatory lesions. This is a case of a diffuse infiltrating lesion within the distal femur with a lot of extra osseous soft tissue. So this turned out to be, understandably, unfortunately, malignant disease involving the distal femur. This is another case which we had recently, wherein you can see that there are phlebolytics within the suprapatellar region, and this was a classical case of a venous malformation in the suprapatellar region. As I mentioned, it's one of the most common causes of the knee pain, and there are multiple etiologies for the same, purely because there are multiple structures which can account for this anterior knee pain. And it's quite a complex anatomy, and we really need to sort of correlate the imaging findings with clinical signs and symptoms to arrive at a particular diagnosis. Thank you.
Thank you, Dr. Srikan Narayanaswamy, for your wonderful lecture. And the third speaker for this session is Dr. Harvey Theo, currently consultant radiologist, pediatric and women imaging, associate professor of KK Women's and Children Hospital. Dr. Harvey will deliver the topic of plain radiograph, normal development, and variants of the musculoskeletal system in children. Dr. Harvey, the time is yours.
Good morning. I'm Dr. Harvey Theo from Singapore. I'd like to thank the organizing committee for inviting me to speak at this meeting. It's been quite a while since we all last met, and I hope that everyone has been well. Today, my topic is on plain radiographs, normal development and variants in children. It is important to recognize normal skeletal development and variants in children so as not to misdiagnose and treat these patients unnecessarily. However, it is also important to note that normal variants may predispose patients to pathology, and I will show you some cases later on. Over the course of this lecture, I would like to go through the steps to take when one encounters a radiograph that one suspects is due to a normal variant but is not sure. I will then go through the normal development and variants of both the axial and the appendicular skeleton. Whenever I encounter a radiograph that I think could be a normal variant, I will often refer to this book entitled The Atlas of Normal Röntgen Variants that May Simulate Disease. Nowadays also, I usually Google search the finding that I want to find out more information on, and often I'm led to pages such as Radiopedia or Radiographics, and I find these websites very useful. So some further steps that I can take are to correlate with the clinical findings, and it's especially useful if the patient is still around. If not, I can ask the clinician to do so. Compare to the contralateral side if an X-ray of the other side was also performed. Follow-up imaging, because sometimes subtle fractures may not be seen on the initial radiograph, but may reveal itself 1 or 2 weeks later in the form of periosteal reaction or callus formation. And if I really want to pursue it further, I can ask the clinician to perform either a CT, MR, or bone scintigraphy. So I'll now go through the normal spine. In the embryo, somites, body segments, through the process of chondrification, will produce the primitive vertebra, which is comprised entirely of cartilage. Then through a process of ossification, a few ossification centers appear. There are 2 in the posterior neural arch and 2 in the vertebral body. And when more bone is laid down within the cartilage, over a period of time, a complete vertebra will form. Okay? If anything should go wrong in this development process, then abnormal vertebrae such as the butterfly vertebra or the hemivertebra or some other rarer ones can be seen. So this patient has hemivertebra, butterfly vertebra, some more butterfly vertebra, hemivertebra, and so on. And this patient has a Vectel syndrome. Okay, this is quite a rare coronal cleft. Okay, yes, as the patient grows, the posterior neural arch begins to complete its fusion, beginning in the lumbar region by 1 year and in the cervical region by 3 years of age. So in the chest X-ray, for example, of a patient of this age, it is quite common to see the unfused posterior neural arch. And this should not be misinterpreted as being spinal bifida. The neurocentral synchondrosis can also be seen, and it begins its fusion from the cervical region at 3 years of age and proceeds to the lumbar region and should be complete by 6 years of age. And this is what the neurocentral synchondrosis looks like on the radiographs. Okay, these lucencies are also frequently seen in the neonate, and these are the nutrient vessels supplying the vertebral bodies. The CT scan is also useful, and these developmental changes can also be quite well seen. You can see the posterior neural arch yet to fuse and the neurocentral synchondrosis here. And the 3D CT also shows these findings quite nicely. The C1 vertebra has a slightly different shape and configuration compared to the other vertebra. This vertebral body is small compared to the other vertebral bodies, and the posterior neural arch is quite large. And you can see that these developmental changes of the yet to fuse posterior neural arch and the neurocentral synchondrosis can still be seen in the C1 vertebra here and here. The C2 vertebral body is also slightly different because it contains the odontoid process or the dens, and there are several ossification centers seen in the dens. Okay, and these can be seen on the CT scan. And where it fuses with the main vertebral body, there are also synchondroses, and they should be bilateral and symmetrical. The dental central synchondrosis fuses by 3 to 6 years of age, but still can be seen and visible till adolescence. Yeah. Right. On first glance, this patient appears to have subluxation of C2 on C3 and C3 on C4. But when we draw the spinal laminar line, you can see that it is still in contact and within normal limits. So this is a case of pseudo-subluxation that is frequently seen in young children. And the way to evaluate this is to draw the spinal laminar line, and it should either pass through C2. Okay, you draw the spinal laminar line connecting C1 and C3, and this line should pass through C2, either touch it or still be very close to it. That same patient had a CT scan done, and you can see that the pseudo-subluxation is still seen. There was no fracture and no soft tissue swelling. So this is a case of a confirmed pseudo-subluxation. Why it occurs is because ligaments are more flexible in children than in adults, and it's believed that the point of flexion in the cervical spine is at C3 rather than at the C5 or 6 level in adults. I'm sure you are familiar with Schmoll's notes. These are herniation of the nucleus pulposus into the end plates of the vertebral bodies, and whether or not it gives rise to symptoms is still open to debate, because we do see patients with Schmoll's notes that are asymptomatic, and on the other hand, we do see symptomatic patients and we discover Schmoll's notes on imaging. It is commoner in children and adolescents than in adults. And here is an example of a Schmoll's note where there's herniation of the nucleus pulposus into the vertebral body. Similar and along the same lines as the Schmoll's note are the limbus vertebra. In this case, the nucleus pulposus herniates between the vertebral body and the unfused ring apophysis. And on radiograph, it can give rise to a slightly fragmented appearance of the ring apophysis. This patient had a CT scan showing this finding, and 2 years later, the finding was stable. Here's an example of another patient with limbus vertebra on MRI, and you can see herniation of the nucleus pulposus between the unfused ring apophysis and the vertebral body. Okay, I'll now move on to the appendicular skeleton. Okay, and at the epiphysis, the appearance of the epiphysis during development, the site, and I'll go through this later, number of ossification centers and sequence of appearance of these ossification centers can sometimes give rise to confusion. So let's see. So this is an 8-year-old with a right hip trauma and pain. And if we see this radiograph on its own, it would appear as if there is a loose bony fragment in the region of the greater trochanter. However, this radiograph is actually half of a pelvic radiograph, and if you look on the other side, you can see a similar finding. So this is normal development of the epiphysis of the greater trochanter and is not due to a fracture. The teaching point here is that developing epiphysis may appear fragmented, irregular, and even loose, apparently detached away from the main bone. Similar finding can be seen in the distal femoral epiphysis, right? And in actual fact, these quote-unquote lesions are not loose or detached, but they're actually still situated within the cartilage of the entire bone. Over a period of time, the irregularity and fragmentation smoothens out. Another area where the fragmentation of the epiphysis may give rise to confusion is the tibial tuberosity here, and when it develops, it can give a very fragmented appearance, and often the clinician will ask, is this Osgood-Schlatter's disease? Well, it depends whether or not the patient is symptomatic. If the patient is symptomatic, then the clinician can diagnose Osgood-Schlatter's disease. Here are two actually asymptomatic patients, and it shows the developing and fragmented tibial tuberosity, but the patient had no symptoms, and this is just a normal development. Okay, if you refer to Pediatric Diagnostic Imaging 11th edition book, you will see this diagram where he shows you the different areas where fragmentation and irregularity of the epiphysis is commonly seen, and these are areas of normal development that should not be misinterpreted as abnormality. Okay. Over the course of development, the epiphysis may give rise to a number of appearances. For example, the cleft epiphysis is quite frequently seen, and the cone-shaped epiphysis occurring within the fingers. Okay, this is a normal hand in a 6-year-old child. You can see that the site of the epiphysis is important. In the first metacarpal, it is situated proximately, but in the second to the fifth metacarpal, it is situated distally. The same finding is seen in the foot. You can see in the first metatarsal, the epiphysis is proximal, but from the second to fifth, it is distal. But occasionally, distal epiphysis may appear in the first metatarsal, and a synchondrosis may appear proximately in the second to the fifth metacarpals. If you look at this on its own, you might think that this patient has a fracture of the proximal aspect of the third metatarsal, but when you look at this radiograph and are familiar with this appearance, you will not make that mistake. And especially in the young children, the proximal synchondrosis and the proximal apparent epiphysis is a frequent finding. And here you also see in this first metatarsal the distal epiphysis. Okay, I'm sure you are all familiar with the elbow crypto, where the C is a capitulum, the radial head, the internal epicondyle or the medial epicondyle, the trochlea, the olecranon, the external epicondyle or the lateral epicondyle. Okay, they should appear in this sequence. In this sequence, C-R-I-T-O-E. Okay, and in roughly 1, 3, 5, 7, 9, 11 years. They appear earlier in the females compared to males. Okay, so C and D is the normal finding. You can see C, R, I. In this case, you have C, the opposite side of the same patient, C. Okay, R, you got R here, R. We have no I, but we have a T. So in this case, you have a CRI. This is a normal finding. In A and B, you have CRT, which is the abnormal finding. So what has happened in that case? It is a medial epicondylar avulsion injury, where the medial epicondyle has been avulsed and is displaced into the position where the normal trochlea is seen. So that is an abnormal finding. It is important to note the correct sequence of appearance of the elbow ossification centers. All right, here is another patient. You have C, you have no R, but you have the internal or the medial epicondyle. C, another patient, no R, similar finding with the I. So this is, instead of CRI, is CIR, okay? This is a normal period, because if you look at the literature regarding the appearance of the ossification centers in the pediatric elbow, you will find that I and R are interchangeable. They usually occur at the same time, or one may occur slightly before the other one. Usually it is R, but sometimes the I may occur first. So if you see CIR or CRI, these are normal findings. Okay. The physis and apophysis may sometimes give rise to confusion. They may appear like fractures. Okay, the appearance at fusion may sometimes also give rise to confusion. And let's look at the synchondrosis. So this patient has a fracture of the clavicle, that's all right. But here is appearance of the pseudofracture, where the physis of the humerus has yet to fuse. And when the radiograph is taken obliquely, this may give rise to the appearance. One may be confused and think that this is a fracture. Similarly, in the calcaneum, when it is taken obliquely, one might be mistaken to think that this is a fracture. But when a true lateral is taken, you will see that this is just the synchondrosis between the apophysis and the main body of the calcaneum. Okay, so the ischiopubic synchondrosis is well known, but when it fuses, it develops what appears as if it is callus formation, but actually this is just a normal finding. It can be asymmetric, in which case it is known as Van Neck-Oldenburg disease, but this is misnomer because it's not actually a disease, it is a normal variant. So let's look at apophyses. These are actually outgrowths of a bone that develop where muscle tendons originate and insert. They also develop ossification centers and will eventually fuse with the main body of the bone and do not contribute to longitudinal growth. Okay, there are two types. There are the sesamoids or ossicles. So let's see. The pelvic bone has many apophyses. They usually begin to appear in the adolescent stage and will complete fusion by 20 to 25 years or in the early adult stage. Here, it's a radiograph, you can see here the crest, AIIS, okay, the ischiotuberosity. Okay, but just because it is a normal variant does not mean you cannot have pathology. Here, you can see that the anterior inferior iliac spine has been avulsed from the main body of the pelvic bone. This is because the rectus femoris inserts at this site, and under stress, it has caused an avulsion fracture. Okay, so sesamoids, I'm sure you are familiar with, occur frequently, seen in the hands and the wrists, and also the ankles and the foot, right? And they're recognized as being normal because they're quite well defined and quantified. Note that this patient has soft tissue. These patients both have soft tissue swelling. That's why the radiograph was performed. And I would like to say that these were not interpreted as being fractures. Okay, so here are two. Here's the os navicularis on the left picture, and this is os trigonum. So the os navicularis is where the tibialis posterior tendon inserts and can sometimes give rise to pain in this area. The os trigonum, also a normal variant, but can give rise to problems because you can see where it is situated between the talus and the calcaneum, and in, for example, ballet dancers or football players, where they plantar flex their ankle a lot, there can be compression between these three structures causing pain in this region. So normal variant, but still causing pain. Okay, so I'm sure you are familiar with the apophysis at the base of the fifth metatarsal. This patient, 12-year-old boy, had pain in this region. Radiograph was performed showing this, and 3 weeks later, repeat, no periosteal reaction or callus formation. So this is a normal apophysis. Another 12-year-old boy, and this time there is a fracture because it is transverse rather than oblique, And you can see 6 weeks later that the fracture had healed. Okay, let's look at the metaphysis. The normal appearance can be fragmented also. It can be dense, or it can be, you can have a spur. Fibrous cortical defects are commonly seen and avulsive irregularities. So let's see. Okay, so dense metaphysis, this is a normal finding. Okay, this is a normal finding because this is the zone of provisional calcification, the zone where calcification of bone is first laid down. So it appears denser than the surrounding adjacent bone. In lead poisoning, for example, this can also be seen, but in those cases, it is very much denser than what you see here. Okay, sometimes a spur of them can be seen in the metaphysis, but it should always be in contact with the main bone itself and not be separated from the bone. If it is separated, then we do worry whether or not this is the classic metaphyseal lesion of child abuse. And here you have it, the bucket handle and the corner fracture here. Yeah, corner fracture, bucket handle fracture. Okay, benign cortical defect or the fibrous cortical defect is very frequently seen, all right? Usually occurring in patients more than 18 months of age, and the highest incidence is 5 to 6 years of age. They can be seen in up to 40% of boys and 30% of girls, and it's so common that it's regarded as a normal variant. It's a touch me not lesion, nothing else needs to be done, and in time they will disappear. Okay. Avulsive cortical irregularity is very commonly seen in the distal femur on the medial side. And this is where the adductor magnus or the medial head of the gastrocnemius inserts. It is almost always 1 to 2 centimeters from the physis, okay, and occurs in boys usually between the ages of 10 to 15 years. You can see that very frequently on the MRI and on the CT scan. And this is where the adductor tubercle where the muscles insert. Okay, so finally we move on to the diaphysis. What we commonly seen is physiological periosteal reaction in the newborns, vascular grooves, and some developmental irregularities in the phalanges. So physiological periosteal reaction in newborn is very commonly seen, usually in patients more than 1 month of age. They peak at 6 months of age, okay? Bilateral, symmetrical, and occurring in the long bones. Why this occurs? Because remember that newborn is about 3 to 3.5 kilograms in weight, but within 1 year, the newborn, at the end of that 1 year, that newborn is about 10 kilograms. So it has tripled in weight. So the patient will grow not only in length, but also in girth, right? And how bones grow in girth is that they will lay down periosteal newborn, right? So this is why we see this appearance in these patients. Okay, vascular grooves are normal findings. Okay, this patient was referred to us for this lucency seen for a CT scan. Okay, and a CT scan showed that this was just a normal vascular channel. It was seen bilateral, symmetrical, and it can be seen in most other long bones. Here, especially the tibia is a common area that we see it. And this patient also had a toddler's fracture, but this was the site of the pain, and this is just the normal nutrient foramen. And all the way back in AJR in 1933, you can see that this was already well described. Okay, this nutrient foramens, nutrient canals seen in the long bones and in the fingers. Okay, so finally, developmental anomalies can often be seen in the fingers. They may not necessarily be abnormal, but this patient came to us for trauma of the second toe. And the resident saw this abnormality, was afraid that this was a fracture, showed it around to several members of our department. And there was as always, if you ask two radiologists their opinion, you get 3 or 4 different answers. So nobody could agree. Some say fracture, some say no fracture. So what we did, we followed up the patient. So we repeated the radiograph. We repeated the radiograph and it was the same. So this was not a fracture, but there was a fracture in the more proximal part of the proximal phalanx. Okay, it was probably seen here, but very difficult to appreciate. Yeah. Okay, so this is also another good lesson. You see one abnormality, you must look again and look for another abnormality in the same radiograph. Okay, so I think I come to the end of my lecture. As you know, normal variants, there are many normal variants occurring all over the body. In the course of this 20-minute lecture, I'm unable to cover everything, but I tried to cover the more common ones that we see which can arise and cause confusion. So if you should encounter any structure that you think may be maybe a normal variant, please check the books, check Google, do some clinical correlation and compare with the contralateral site. And you may even do follow-up imaging or further imaging with CT or MRI. Finally, remember that normal variants may also be pathological. Just because you see a normal variant does not mean that the patient does not have any pathology. Thank you very much, and I wish you all the best.
Okay, thank you, Dr. Harvey Teo, for the insightful lecture. All participants, if you wish to submit question to our speakers, please type your question in the chat box and the speakers will answer the question for you. And last speaker is Dr. Tarika Salama. She is consultant radiologist of Department of Radiology, Faculty of Medicine, University of Indonesia. Dr. Tarika will speak about juvenile idiopathic arthritis, what radiologists should know. Dr. Tarika, the time is yours.
Good day, everyone. I'm Tarika Salama from University of Indonesia, Jakarta, Indonesia. Today, I will present imaging of juvenile idiopathic arthritis, what radiologists should know. I have nothing to disclose. Our agenda for today is, first one is introduction, and then we will move to radiography, ultrasound, and MRI modality to assess juvenile idiopathic arthritis. And then we will move to treatment monitoring, and we will end with summary of imaging modalities. First, we move to introduction. Juvenile idiopathic arthritis, or GIA, previously known as juvenile rheumatoid arthritis or juvenile chronic arthritis. It is an heterogeneous inflammatory disorder of unknown origin and the most common pediatric rheumatoid disease. Diagnosis can be made if it is involving one or more joints, diagnosed at less than 60 years old, and also present for more than 6 weeks. We have to exclude other causes of arthritis, including infection, before we make diagnosis of GIA. The goal of imaging is to detect inflammatory changes before significant joint damage occur. Subtypes of GIA are as follows. The first one is systemic onset, and then polyarticular or oligoarticular, polyarticular with positive rheumatoid factor, polyarticular with negative rheumatoid factor, thoracic enthesitis-related arthritis, and other type or the undifferentiated form. The most common joint to be involved is knee, followed by hip joint, wrist joint, sacroiliac joint, spine, and temporomandibular joint. Now we move on to modalities to diagnose GIA. Radiography is the most readily available imaging modality. It can be used to rule out other bony abnormalities. But we must remember that an immature skeleton can be causing difficulty in evaluation of GIA. Structural joint damage appears late in the course of the disease, so a radiography can be used to early diagnosis. We can see the indirect evaluation of soft tissue and also the cartilage defect from radiography. The radiographic features are signs of soft tissue edema and also periarticular osteoporosis, periosteal thickening or periosteal reaction, developmental or ossification center maturation disorder, epiphyseal disorders such as ballooning, and also erosion, joint space narrowing, and finally ankylosis. Here in this patient, we can see that there's some thickening in the soft tissue of the ankle, especially at the anterior recess and also in the Kager fragment. So we can say that this patient has soft tissue edema. And also in this patient, in another patient, we can see that there's periarticular osteoporosis with erosion of the carpal bones. And also we can see that there's some slight joint space, some slight soft tissue edema and also joint space narrowing. Here in the follow-up of this patient, we can see that there's progressive changes in the inflammatory changes here in the wrist joint of this patient. We can see that there's more pronounced joint space narrowing with erosion of carpal bones, and we can also see subluxation of the proximal interphalangeal joints of the fifth digits, and also of the metacarpophalangeal joint of the first digit. Ultrasound usually used for early diagnosis, treatment monitoring, and also determine remission. We can see spectrum of inflammatory and non-inflammatory changes. We should find the sign of synovitis, including in patient with subclinical synovitis. And then we should also assess for signs of enthesopathies and also for intra or extraarticular fat edema. Here in this patient, we can see that there's thickening of synovium with some fluid collection. In MRI, we can assess soft tissue inflammation, including inflammation of the tendon sheath. We can also see bone marrow inflammation characterized by bone marrow edema. MRI is also superior to describe early destructive changes, and it is the modality of choice for axial skeletal involvement. We can also use MRI to exclude other diagnoses such as osteomyelitis. Here in our patient, we can see that there's some thickening and also edema of the synovium in the knee joint with some fluid collection in the suprapatellar recess. And also we can see here there's a periosteal reaction, solid periosteal reaction at the distal metaphyseal of the femur, which is periostitis. And also we can see bone marrow edema in the antecedent. In another patient, referred to as to exclude infection of the hip joint, of the right hip joint. Here we can see from the MRI there's bone marrow edema in acetabulum and also in the femoral head. And also we can see that there's significant bone marrow edema in the antesis, both in the right femur and also here in the left femur. And also we can see here, there's a bone marrow edema in the anti-cyst, more pronounced on the right side. So this patient is later diagnosed as juvenile idiopathic arthritis. Now we move on to treatment monitoring. In radiography, there are scoring methods for adult patients with rheumatoid arthritis, but those scoring are not suitable for children because it is based on joint space width evaluation, which could be problematic in ongoing ossification process in children. Poznansky scoring, here we can measure the metacarpal, the second metacarpal, and also the height of the carpal bones here. It can only be used in the wrist joint and also can only be used until physeal plate closes and until the second metacarpal is developed completely. So nowadays it is very rarely used. Ravelli then adapt the sharp van der Heide scoring. Ravelli added 5 sites. Here we can see the second to the fourth metacarpal base and also the capitate and the hamate bones. In addition to other bones assessed in sharp van der Heide scoring. Joint space narrowing is used as indicator of hyaline cartilage and epiphyseal damage. Ultrasound is used to assess the activity of synovitis, tenosynovitis, and bursitis, characterized by synovial vascularization, as we can see here, and also presence of joint effusion. We can also evaluate the progression of joint destruction, such as hyaline cartilage and epiphyseal defect, and also bone erosion. In ultrasound, mostly we use qualitative assessment. Sparches et al. Found that power Doppler ultrasound correlate with clinical assessment and also more sensitive than erythrocyte sedimentation rate and C-reactive protein level as a marker of inflammation. Gillis and Morin et al. Found that maximum synovial thickness of more than 3 mm or synovial volume of more than 3 milliliters indicate active synovitis in the knee joint. In MRI, usually we describe a qualitative assessment such as the location, the signal intensity, the presence of bone marrow edema, the presence of erosion, and the location, and so on. But there are also some semi-quantitative measures such as juvenile arthritis MRI scoring on chambers for knee joint, and also the outcome measures in rheumatology clinical trial or OMERAC, which use for grading system depending on the surface of damaged bone, and also the presence of synovitis and osteitis in 15 sites, including wrist bones, metacarpal bases, distal radial, and distal ulnar epiphyses. Dynamic contrast enhanced MRI also shows some promise in assessing the response to treatment. Usually, we use the rate of synovial enhancement. Contrast-enhanced MRI can be used to visualize cartilage defect and also the cartilage vascularity pattern, which is a response to ongoing inflammation. Now we will end this presentation with a summary of modalities. Here with modality. In the knee joint, radiography is used at diagnosis to exclude other diagnoses and also to assess growth disturbance, while ultrasound in the knee joint is used for joint effusion and synovitis evaluation and also to guide injection. MRI with contrast administration can be used to evaluate synovitis and also to detect structural abnormalities. In the hip joint, we can see the radiography has a role at diagnosis and also to exclude other diagnoses and to assess growth disturbance and destructive changes, while the role of ultrasound is to diagnose joint effusion in sinusitis, and also to guide injection. MRI should be used at baseline and to follow up if US finding is equivocal. In wrist joint, we use radiography at diagnosis and also for follow-up, and also to evaluate growth disturbance. Ultrasound is used to diagnose joint effusion, tenosynovitis, and synovitis, and also to guide injection. MRI is used to assess effusion and synovitis, but we should be aware that there are normal variants in the wrist joint mimicking structural abnormalities. In sacroiliac joint, radiography and ultrasound are not indicated. MRI should be used in suspected axial spondyloarthritis with the MRI of sacroiliac joint, hip, and also consider MRI of the spine. In spine, radiography is used to assess alignment, to assess growth disturbances, and also to see bony changes. Ultrasound is not indicated in evaluation of GIA in the spine. MRI should be considered at baseline with contrast administration. While for temporomandibular joint, radiography and ultrasound are not indicated. An MRI, we should use the fluid-sensitive sequences with open and closed mouth position, and also we should add contrast to assess for synovitis. I think that's all I can share with you. Thank you and have a good webinar.
Okay, thank you, Dr. Tarika, for the wonderful presentation. Dear all participants, this is the end of the first parallel session, but wait, stay seated in your seat. Yeah, thank you to all speakers of pediatric session. And now we will continue to best paper of AMS. Dear distinguished presenters, participants, and all organizing committee, welcome to the best paper AMS session. We will have the paper presentation from Professor Nizar Al-Naqshbandi. Professor Nizar Al-Naqshbandi is Canadian board-certified musculoskeletal radiologist, professor of musculoskeletal and interventional radiology from King Saud University Hospital, Riyadh, Saudi Arabia. Professor Nizar Al-Naqshbandi will bring us the best paper titled The Therapeutic Effect of Geniculate Nerve Radiofrequency for Chronic Knee Pain. The time is yours, Professor.
Hello, my name is Nizar Al-Naqshbandi, and I'd like to thank this organizing committee for giving me the opportunity to share my work about the therapeutic effect of geniculate nerve radiofrequency for chronic knee pain. Overview of this lecture, we'll be talking about disclosures, objectives, material methods, conclusion, and examples of the procedure and its outcomes. I have nothing to disclose. The objectives of this talk is to determine the therapeutic effect of geniculate nerve radiofrequency for chronic knee pain by image-guided procedure done on an outpatient basis by the interventional musculoskeletal radiologist. The study has been approved by the hospital's ethics committee. A total of 21 patients ranging in age from 50 to 70 years of age, suffering from moderate to severe osteoarthritis of the knee, graded by the Kellgren-Lawrence classification, grades 3 to 4. All patients failed conservative measures with non-steroidal anti-inflammatory drugs or with physiotherapy. All 21 patients consented to undergo image-guided radiofrequency ablation of the geniculate nerves. A visual analog score was measured at baseline, 1 week, 4 weeks, and 12 weeks post-procedure. These are the results. This is a busy table showing you the age, the number of the patients from 1 to 21, ages from 50 to 70, and at the baseline, most patients had a grade of 8, 9, or 10 out of 10 on the visual analog scale. And at 12 weeks, most patients have dropped to 1 to 2 and almost to 4 out of 10 on the visual analog scale. There was a significant reduction of pain between the baseline and at 12 weeks with a p-value measuring less than 0.05, significant reduction. This is to summarize the busy table. This is a scattered plot graph showing the response of pain in the visual analog scale between the baseline and 12 weeks post-procedure. As you can see, the patients who had a scale of 10 out of 10 on the visual analog scale have dropped to almost 2 or even 4 or even 1 out of 10. So the conclusion is that radiofrequency ablation of the geniculate nerves of the knee has a significant pain reduction and functional improvement in the elderly patients with chronic osteoarthritis of the knee. It is therefore effective treatment of such cases, and it should be implemented by all interventional musculoskeletal radiologists and has significant role instead of just corticosteroid injections. I'll be giving two examples of the procedure. This is a schematic presentation of the radiofrequency ablation probes placed at the medial superior and medial superior lateral and inferior medial geniculate nerves. This is the exact representation on the lateral view of the needle placements. Procedure is done with image guidance, either with a C-arm image intensifier. The patient are usually awake under conscious sedation and local anesthetic. Usually an IV line is placed on in the patient, and broad spectrum antibiotic is given. Cefazolin 2 grams I give intravenously at the start of the procedure. The needle is placed percutaneously towards the shaft of the condyle, epicondyle at the femur, superiorly, medially, superiorly, laterally, and inferiorly, medially. We avoid the inferior geniculate nerve laterally, as it can affect the perineal nerve with disastrous outcome if the perineal nerves get ablated. After that, the probes are connected to the radiofrequency ablation. We use the Avenus cool leaf machine. We test for the sensory stimulation at 50 Hertz, 1.2 volts and 1.6 volts. Patient usually express heat at 1.6 volts, then you know you're at the geniculate nerve. And then we do the motor stimulation at 2 Hertz at 0.5 volts interval. If there is any shivering of the muscles or reticulation or speculation, then we move the needle slightly laterally as to not affect the motor nerve component of the geniculate nerve. We are only aiming for the sensory nerve. The electrode tip temperature is then raised to 60 degrees for 180 seconds. And one radiofrequency lesion is made for each geniculate nerve. This is an example of 69-year-old male, KL grade 4, severe osteoarthritis. Pre-procedure score was 9 out of 10. Placement of the needles medially and laterally superiorly and inferiorly medially only is, you can see from the C-arm image intensifier. Another excellent procedure is to help these patients who had total knee replacement. As you know, 20% of the patients who had previous total knee replacement will continue to have pain, and if there is ongoing pain despite conservative treatment and infection and hardware loosening and fracture is ruled out, then you can give them the option of radiofrequency ablation of the geniculate nerve, as in this example of this patient who is 70-year-old, had a previous total knee replacement 2 years ago, and all other causes have been ruled out of infection, hardware loosening, or fracture were ruled out. He had the radiofrequency ablation, and the pre-pain score at baseline was 8 out of 10, and at 12 weeks was 1 out of 10. So this is my short talk about radiofrequency ablation. I think this is a procedure that should be implemented by most musculoskeletal interventional radiologists. The procedure is also being done by our colleagues in anesthesia, pain management, and collaboration between these services should be implemented. Thank you very much for your attention. I appreciate your time. Goodbye.
Yeah, very insightful paper from Professor Nizar Al-Naqshbandi. Thank you, Professor. And also congratulations for you as the winner of the Best Paper AMS Award. Okay, distinguished presenters, participants, and all organizing committee, we still have one presentation from our supporting partner, Mulia Husada Jaya, that will be conducted by Mr. Rizky Heru Setiawan. Mr. Rizky Heru Setiawan, the time is yours.
Selamat siang, terima kasih atas kesempatan yang diberikan kepada kami. Perkenalkan, nama saya Rizky Heru Setiawan, saya General Manager untuk PT Mulia Husada Jaya. Dan pada kesempatan kali ini saya ingin memperkenalkan PT Mulia Husada Jaya kepada teman-teman radiolog di kesempatan kali ini. PT Mulia Husada Jaya berdiri tahun 1995 dan hingga hari ini kita sudah ada memiliki karyawan 350 orang yang tersebar di seluruh Indonesia. Berikut adalah visi dan misi kami PT Mulia Husada Jaya. Visi kami adalah menjadi medical supplier terbaik di Indonesia dengan reputasi yang baik dan mendunia. Hingga kantor pusat kami berada di Lompo Batang, nomor 3, Surabaya, di Jawa Timur. Bagi teman-teman radiolog yang ingin mencatat call center kami, bisa mencatat call center kami di bawah ini. Dan jika ada keluhan atau kendala atau butuh refresh training dan lain-lain, bisa menghubungi call center tersebut. Hingga hari ini kami memiliki 14 kantor cabang yang tersebar di seluruh Indonesia, mulai dari Medan, ada di Pekanbaru, ada di Jakarta, di Bandung, hingga sampai ke Papua. Berikut adalah bisnis partner kami. Jadi kita mengageni beberapa produk, mulai dari G Healthcare, mulai alat-alat CT scan, MRI, ultrasound, cath lab angiografi, serta juga nuclear imaging. Dan juga tidak lupa kita juga mengageni PEX. Kita PT Mulia Husada Jaya sudah 27 tahun menjadi channel partner dari GE Healthcare, waktu yang tidak pendek, waktu yang sudah cukup lama, jadi kita sudah hand in hand dengan GE Healthcare memberikan pelayanan terbaik bagi teman-teman radiolog di seluruh Indonesia. Selain itu kita juga mengageni untuk alat-alat proteksi radiasi dari Kiran, kita mulai dari apron, tiroid, gonad, hingga kacamata dan headset shield. Selain itu juga kita memegang satu brand juga untuk diargem, jadi dari Korea. Diargem ini kita mengageni untuk alat-alat yang fokus pada X-ray. Jadi ada X-ray analog, X-ray digital, X-ray mobile, dan flat panel detector. Setelah ini saya ingin mengenalkan kepada teman-teman radiolog sekalian, ada 3 produk kami yang ingin kita kenalkan, mulai dari ultrasound, CT scan, dan MRI. Mungkin waktu dan kesempatan saya memulai dulu dari ultrasound. Jadi video produk yang akan kita tayangkan adalah video dari ultrasound yang fokusnya pada dedicated radiologi, itu dengan tipe Logic E10. Oke, mari kita bisa lihat sama-sama video produk berikut. Terima kasih. Oke, demikian video dari video produk perkenalan untuk Logic E10. Mungkin untuk sebagai informasi teman-teman, Logic E10 ini merupakan platform ultrasound dedicated radiologi yang tertinggi yang yang dipunyai oleh GE Healthcare yang dipasarkan di Indonesia. Dan Logic E10 ini sudah tayang dan tersedia di e-katalog bagi teman-teman radiologi, bagi teman-teman radiolog yang membutuhkan informasi lebih lanjut dapat menghubungi teman-teman kami yang ada di cabang. Berikutnya kita akan masuk pada salah satu produk unggulan kami juga, CT scan tipe Revolution Maxima. Tipe Revolution Maxima ini merupakan tipe terbaru yang dikeluarkan oleh GE Healthcare dengan CT scan 64 hingga 64128 dan bisa di-upgrade ke up to 500 flash speed. Oke, tanpa berlama-lama lagi kita lihat video berikut. Oke, kita telah saksikan sama-sama untuk video CT scan dari tipe Revolution Maxima. Salah satu keunggulan dari tipe ini adalah tipe ini sudah mengadopsi teknologi AI atau Artificial Intelligence dan ada salah satu fitur yang unik dari GE yaitu auto positioning. Kalau kita tadi sempat lihat ada semacam satu kamera. Kamera ini adalah membantu teman-teman dari radiografer maupun teman-teman dari radiolog untuk bisa automatic positioning pasien pada saat pemeriksaan CT scan. Jadi fitur ini akan membantu isosentris pasien supaya membantu workflow dari teman-teman untuk mempercepat proses pemeriksaan. Berikutnya, saya ingin mengajak teman-teman radiolog untuk mungkin beberapa teman-teman sudah tahu ada salah satu fitur baru dari GE Healthcare yaitu air coil yang selama ini mungkin teman-teman dari radiolog tahu bahwa coil ini salah satu bagian terpenting dari MRI dan GE Healthcare mengembangkan teknologi air coil untuk membantu dan meningkatkan kenyamanan pasien pada saat pemeriksaan MRI. Mungkin tanpa berlama-lama, kita bisa lihat video berikut. Terima kasih atas kesempatan yang diberikan kepada kami, PT Mulia Usada Jaya. Saya mewakili PT Mulia Usada Jaya mengucapkan terima kasih banyak pada Perami dan sukses atas terselenggaranya 10th Annual Meeting of IMRS dan 24th Asian Musculoskeletal Society. Terima kasih dan sukses selalu dan sehat selalu. Terima kasih.
Yeah, thank you for Mr. Rizky Heru Setiawan for excellent presentation. All participants, after this, we will have lunch break from now until 1:30 p.m. And please enter again Hall A and Hall B for last session today at 1:30 p.m. Hall A with topic of post-operative imaging and interventional MSK, and Hall B will be MSK infection. Each session, we will have 4 distinguished speakers. See you at the parallel session.
for Dr. Aki Kumar.
Good morning, good afternoon, and good evening. Before I start, I would like to thank the Indonesian Musculoskeletal Radiologist Society and the Asian Musculoskeletal Society for inviting me today to speak here. So let us start. I'm Dr. Rakhi Kumar Paruchuri from Hyderabad, India, and I will be talking about orthopedic hardware, recognizing complications. So, this is what most of us radiologists are like when we think about so many screws, pins, bones, type of plates, prostheses, and the list goes on. And we are daunted and often feel very scared. How can one be expected to remember all of these names and types? Is just impossible, right? And if you see, most reports are still very basic. So like, for example, one report will say status post THR on the right, metallic implant seen in situ, and position is as shown for orthoperusal. So we have to come face the fact that orthopedic hardware is here to stay, and it is time to face our fears. This will require a good understanding of the most commonly performed orthopedic procedures for accurate interpretation and the ability to differentiate normal from abnormal findings. So hardware can be used for joint replacement, for fracture fixation, and within the spine. I'm not going to cover the spine today because I frankly don't have enough time. So let us review some questions which are common to all. From a clinical standpoint, you need to see in a fracture as to, like, has the alignment of anatomy been maintained? What is the integrity of the adjacent bone? Has the joint been in a joint replacement? We want to see, is the patient pain free, and is there restoration of function? Common to both, we want to see, has the patient been remobilized, and whether the blood supply is maintained or not. From a radiological and a surgical standpoint of view, you want to evaluate the type of the fixation, the alignment of the device, the integrity of the adjacent bone, and the integrity of the device. So when it comes to radiological evaluation, yes, we can use all modalities, but conventional radiology, yes, this old dinosaur is still the star of the show. Two basic views are actually good enough. You need two orthogonal views, one AP and one lateral. You can use specialized views like a skyline view for the knee, post TKA, or a true lateral view for the hip. Remember to ensure inclusion for the entire prosthesis and evaluation. Especially, you must look at the pre-op, especially in trauma, to understand what is the type and the mechanism of the injury, and immediate post-op, or which can be taken at discharge, and then the reviews can be followed up according to the protocol in your hospital. But whenever the patient comes back to you, remember to review all previous radiographs. Now, joint replacement can be performed for every single joint. I'm going to cover mostly the hip and the knee today. Now, these are the most commonly performed orthopedic procedures. And the main components of a prosthesis are made up of metal alloys or ceramic in the hip and a plastic polyethylene liner. These can be fixed using cement, which is a polymethyl methacrylate, and it is used less like a adhesive but more to fill up the spaces. And in the uncemented mechanism, we use a press fit mechanism where a slightly larger size of the prosthesis is taken and then it is reamed into the cavity. It is expensive, but it is gaining popularity because of increased span and survival rates, and it is generally used only when it has a good bone stock. So this is a bipolar hemiarthroplasty. We can say that this is bipolar because we can identify that we can still see the acetabulum, and we can see the cement around the stem. In a hybrid type of the total hip arthroplasty, you can see that the stem is cemented, and in the reverse hybrid, you can see that the acetabulum is cemented, but not the femoral stem. In a non-cemented type, total hip arthroplasty, neither the acetabulum nor the stem are fixed using cement. In the hip, in the knee, you can again have a cemented type or an uncemented type. Now, initial post-op radiographic evaluation, you should look at the placement of the component so that you can say that it is placed well and the chances of failure is less. I can't cover all. Just quickly, I will tell you that a limb length discrepancy of less than 1 centimeter is acceptable. When you look at the lateral inclination angle, this angle should be between 30 to 50 degrees. If this angle is less, then the hip is stable, but the abduction will be reduced. And if this angle is more, then there is a higher risk of dislocation. It's also very important to look at the stem. The stem should be in a neutral position or a slightly valgus position. That means it's touching the medial cortex. Remember G for G, valgus for good. If it is in a varus position, then there is a high risk of failure. In the immediate post-op period for the knee, look at the mild valgus position is good, and look at the articular surfaces of the tibial component. They should be in contact with the tibia. There should be no overhang, and the femoral component should also be at 90 degrees to the femoral shaft. Now, normal findings at follow-up. Now, periprosthetic lucencies can be identified in both cemented and non-cemented arthroplasties, and they can be seen at the bone cement or the bone processes interface. And to describe them, standard zones have been, described for the both hip and the knee joints. In the hip joints, you have the acetabular zones where you starting from lateral and going down to medial, you have zones 1, 2, and 3. For the hip, on an AP view, starting from the lateral aspect going around, so you have 1, 2, 3, 4, 5, 6, 7 coming medially, and on a lateral view starting from anterior to posterior, you have zones 8 to 14. In the knee as well, you have these interface zones, and for the femur you have them on a lateral view, whereas on the tibia you have them on the AP, and again you have on the lateral view as well. Try to use these zones when you're writing a report. In the knee, you can quantify them, and anything, if the sum of these lines is more than 10, this predicts an impending failure. Now, these periprosthetic lucencies should be less than 2 mm, and they are generally seen with a sclerotic margin, right? And this suggests a fibrous ingrowth providing sufficient stability. And if they are non-progressive for more than 2 years, then post-surgery, then these are said to be a good and stable finding. In the acetabulum, these findings can be seen in zones 1, which are normal, and in the hip, in zones 1 and 7, they are again normal because of the pressure effects. I will tell you later. Anything in all the other zones, they should be considered abnormal, and always compare with the previous side. If you're seeing any abnormality or any increase in the width, think of it as loosening. Now, in the hip, you can also have bone remodeling, because what happens is that the pressure which is coming down, the load which is being transferred down, it comes from the body, it comes to the artificial joint into the femoral implant and goes into the host bone. So this is called as stress shielding. And what actually happens is that this areas, the zones 1 and 7, the calcar area, they don't receive much of the stress. So they lose out on the bone density. Again, because of the stress only, in the 3 and 4, they can be increased densities, which is a strong indicator of stability. Component migration of 1 to 2 years is also is accepted, and it is normal. It happens more in the uncemented than the cemented fixation. In the knee, the tibial component is more likely to show some subsidence, and any progressive movement after 2 years after surgery or more than 10 mm is considered abnormal. Now let's look few of the complications. Most common that we see is loosening. So these are the common questions to all. So let's look at this. So you can see this was a post-op radiograph. Immediate post-op looked fine. 2 years down the line, we can see definitely there is periprosthetic lucency, which are seen at the bone cement interface, especially in zone 4, suggestive of loosening. So this is common to all the processes, and it is often a delayed complication and happens because of repetitive mechanical stress, because of cement bone, and it can occur at the cement bone cement processes or the processes bone interface, and generally seen within 6 months in the cemented type and at around 2 years in the cementless type. If the lucency is less than 2 mm wide, that is normal. We've already told that. Any progressive lucency is more than 2 mm or a development of new irregular areas, think of loosening, and always that is why we need to compare with previous films. So let us look at this. So what is the type of the fixation? This is a total hip arthroplasty. And is the alignment of the device there? No, you can see that the head is no longer in the center of the acetabular cup. So this means that there is a wear of the liner. So alignment of the device is lost. Look at the integrity of the adjacent bone. In zones 1, 2, and partly 3 of the acetabulum, we can see large areas of lucencies, and so similarly in zones 1 as well. So adjacent bone is lost. But at this point of time, the device is normal in position. It has not yet dislocated, but you can see the angle of inclination is slightly higher. So presently, the integrity of the device is maintained. Another case here, look at the type of the fixation. This is a unicompartmental knee arthroplasty. How is the alignment of the device? Alignment of the device looks pretty okay, but look at the adjacent, the integrity of the adjacent bone. We can see there are large periprosthetic lucencies. This is aseptic loosening, and the integrity of the device is still maintained. So this is okay. This is another patient, simple case from Learning Radiology website. You can see this is immediate post-op, and then post-op we can see it's 4 years later down the line, we can see periprosthetic lucencies along the tibial plate. This is consistent with aseptic loosening. Additional radiographs, additional features, what you can see is look for migration of the component or any change in the position, look for fracture of the component. There can be motion of the component with stress views, collapse on the underlying bone, and look for shedding of polyethylene beads. Now, infection or septic loosening is a dreaded and delayed complication, and it is sometimes very difficult to differentiate from aseptic loosening and particle disease. Radiographically, look for irregular periprosthetic lucencies. Look for periosteal reaction. This is a very strong sign suggesting infection. Look for bone destruction. Look for additional signs such as soft tissue swelling, a large joint effusion, and abscess formation or air locules, which you generally don't see that often these days. You must compare with previous radiographs because acute infection has generally a more rapid and aggressive course. Other modalities, yes, they are helpful now. Even a nuclear medicine scan, if you do a 3-phase bone scan, which is what is preferred in our center, you will see increased uptake in all the 3 phases. Sometimes you may have to do an aspiration. You can use ultrasound guidance, and this yields better results if no prior antibiotics have been given. Now you can see this case, this is a case of septic loosening. We can see large irregular areas of destruction. Another area, periacetabular, within the acetabulum, periprosthetic large area of hypodensity, which was identified as a abscess on CT. This is a case of the knee where you can see irregular lucency surrounding both the tibial and the peri and the femoral lucency processes. You can see a soft tissue lucency as well as soft tissue density, and you can see some destruction of the bone consistent with infected joint processes. So infection is often a 2-step treatment where you remove the processes, completely debride the area. You can fill the area with antibiotic loaded spacers, and then you come back and again do a repeat surgery. Again, in the knee also you can have these antibiotic loaded cement spacers. Now let's come to fractures. So fractures can happen in the adjacent bone, and these are typically seen in the early preoperative, post-operative period. In the hip, it is more common in the femur with revision arthroplasty and in uncemented type of fixation. Intraoperatively, these often occur in an uncemented fixation because of a press with method. In the immediate post-op period, these can generally occur because of minor trauma, and delayed, it is most commonly seen because of a varus alignment of the stem. You can use the Vancouver classification for periprosthetic hip fractures, which will guide you to the management as well. This you can see here, there's a periprosthetic fracture in the shaft, this was a unipolar type of arthroplasty, which was then fixed with a total hip arthroplasty and circlage wires were placed. This is a periprosthetic, this is a case where we have used an acetabular cage, and we can see that it is malaligned and dislocated. Now, in the knee, both the tibia and the femur may fracture, but the supracondylar region is one of the most common places where it happens, and these can occur both intraoperative and the post-operative periods. Even the patella can fracture at any time. Now, hardware fracture is usually a delayed complication, and it commonly is because of a long-term repetitive stress. In the stem, like a femoral stem, this generally happens because the stem is more fixed and less malleable than the adjacent bone, suggesting a metal fatigue. And in the knee, the fractures of the periprosthetic condylar and tibial components are uncommon, and you can get them, especially more commonly for the tibial component, if there is a malalignment or an improper cementing, severe polyethylene wear, or the correct size of the implant has not been used. They can also dislocate. This can occur in both the early or the late post-operative period. It can be traumatic and atraumatic, and generally occurs if there is inadequate strength from the support provided from the adjacent ligaments and muscles. This was a case where a hemiarthroplasty was done for the shoulder, and the patient had a sudden jerky movement while getting up, and the coupling was lost, resulting in a dislocation. Now let us look at few soft tissue abnormalities. Now particle disease is generally just a body's response to the metal debris. It is also called as metallosis or ALVA, aseptic lymphocytic vasculitis associated lesions or pseudotumors, and I like to use the umbrella term adverse reaction to metal debris. And this can be produced by wear and tear of metal on metal processes, which that leads to deposition of the metal debris in the joint and the adjacent soft tissues because of the polyethylene liner wear or because of the bone cement used. It is more common in the hip joint, and its appearances overlap with that of infection and aseptic loosening. Now, this is generally seen as a foreign body granulomatous reaction, and you can see multiple punctate particles or beads, and you can see foci of endosteal scalloping. No periosteal reaction may be seen. Again, you look for asymmetrical position of the head and large lucencies. Now, heterotopic ossification is also can be seen in in the hip more commonly than the knee. It can occur anywhere and lead to joint stiffening. In the hip, you can use a Booker classification to grade it, and like you can see, this is a grade 4 where there is a complete almost like a joint ankylosis. Now, in the knee, you have specific type, but let's skip this. I'm running short of time. So coming to a fracture, again, we are going to ask the same questions to ourselves, but there's a slightly different approach. First, I want you to ask yourself, what is the type of the injury? Has a realignment of anatomy been obtained? Look at the integrity of the adjacent bone. So look at the type of the fixation, the alignment of the device, and integrity of the device. Always try to look at the initial injury, the immediate post-op, and then the follow-up post-op radiographs. So why should we surgically fix a fracture? Because when you have a direct healing, the healing is, you can get absolute stability, interfragmentary compression is there, there's an anatomic reduction, and this healing is very predictable. So that is why it is preferred. So let us look at this type of this case. This is a post-total knee arthroplasty. Type of the injury is a supracondylar fracture with fractures going into the shaft. Alignment of anatomy, yes, that has been obtained. The integrity of the adjacent bone, yes, that is there. Look at the fixation. There is a compression plate with screws. Yes, the cortical screws can be seen crossing the other cortex, but we can mention this, but orthopods are generally not very bothered by this. The alignment of the device is there. Integrity of the device is also maintained. Let's look at this case. What is the type of the injury? We can see that this was probably some malunited midshaft fracture, and now there is an subtrochanteric fracture. Has the alignment of the anatomy been maintained? In my opinion, not really. Look at the integrity of the adjacent bone. We can see very sclerotic margin suggesting a non-union. So integrity not there. Fixation, they have used plate and screws. So the alignment of the device, yes, clearly lost, and so is the integrity of the device. So this is how we will write in our report. Again, this patient injury is a distal shaft of the fracture injury. Realignment for this patient, yes, it's there. The integrity of the adjacent bone, no, not there. There is a non-union. Fixation, they have used compression plate and screws. Alignment of the device is there. Sorry, it is lost because you can see that there is loss of contact with the bone, and you can see periprosthetic lucencies, suggesting loosening, and integrity of the device, it is lost. This patient was taken up for surgery and it was removed. This patient post TKR came back with a fracture, and again this was fracture. This was a morbidly obese patient. In this patient, look at the type of the injury. I don't have a previous radiograph, but I can assume that there was an intertrochanteric fracture or a fracture neck femur. That is why they have used cannulated screws. Realignment of anatomy, I don't have previous radiographs, so I don't want to mention it now, because now, yes, we know that integrity of the adjacent bone is not there. There is a clear-cut AVN. Look at the type of the fixation. Screws are there. Alignment of the device is there. Integrity of the device is maintained. Another patient, look at this case. This is a subtrochanteric fracture, and look at the alignment of the anatomy. Yes, it is there. The integrity of the adjacent bone is lost because there is a non-united fracture and there are periprosthetic lucencies suggesting loosening. Type of the fixation is a DHS. Alignment of the device is lost. You can clearly see that the device is now placed in an eccentric position. The integrity of the device is, however, maintained. This is the trimalleolar fracture. Realignment of anatomy is there. Integrity of the adjacent bone, no, it is not there. You can clearly see this disintegration almost. This is an infection. The type of the fixation is correct. Alignment of the device and integrity of the device is still maintained. And this case, this was an infective prosthesis, and this was then treated with antibiotic-loaded K-vials. This patient came initially, and it had a fracture of the tibial shaft as well as the femur, but because the fibula, but because the fibular fractures were not fixed because of this continuous varus stress, the patient went into refracture. So I hope that I have been able to answer all the questions, and we can now add all of these points to our reports. I would like to acknowledge and deep gratitude to Dr. Hema and Dr. Rajesh Racha for their constant guidance. These are my references. Thank you. I leave you with pictures of my last trip to Bali in 2018. Inshallah, I'll visit you soon again.
Thank you, Dr. Rahi Kumar Karachuri, for your very wonderful presentation. And then we will move to our second speaker, Dr. Rupert Dutta, the Senior Consultant from Kamtoxin Hospital, Singapore. He will talk about spinal troubles, post-op spine complication, what radiologist needs to know. Dr. Dutta, line is yours.
Hello, everybody. So today I'll be talking about post-op spinal complication, what the surgeon wants to know, and what we as radiologists should be addressing, reporting on a plain X-ray, CT, or MRI, some of the pertinent points that we should be looking into. Nothing to disclose. Imaging plays a key role in the evaluation of spine before and after surgery. Appropriate imaging techniques and knowledge of the advantages and limitations should be known. There are a wide range of immediate and post-op complications which we should be aware of. And through this lecture, I wanted to stress on these two components: adjacent segment disease, often referred to as ASD, and proximal junctional kyphosis. So spinal surgery generally are done for dystrophism, scoliosis correction, and most commonly for trauma and degenerative disease. So this is primarily done for spinal decompression, which is done as laminotomy, laminectomy, and fascectomy, discectomy. Stabilization of the motion elements of the posterior elements is done with rods in place, as we see here. Translaminar or pedicular or facet screws, transpedicular screws, as we see here. Interbody spacers here. This is how it looks on a sagittal reconstruction on CT. There is fusion of the disc spacer here. So there are different kinds of disc spacers, and essentially it contains of a cage within which there is prosthetic material, which may be synthetic material or even bone grafts. The modalities employed are primarily plain radiography, CT and MRI if need be, ultrasound to look for infections or collections, nuclear medicine also to detect early infection. Now this is important. OMAR, we all are aware of. Orthopedic metal artifact reduction sequences are employed to reduce artifacts, which used to be particularly seen with metallic prostheses. It's so bizarre, we barely get to see anything of the spinal within the spinal canal. So there is newer material with titanium used and lesser artifacts with these. And the newest of all are the PEEK materials. These are all synthetic materials with considerably reduced artifact. And like we see here, there is hardly any artifact with nice screws seen through the vertebra. So all are complementary to each other. And parameter optimization with metal artifact reduction sequences are necessary for better evaluation. And ultrasound is helpful for culture and brain images. Nuclear scans to look for early infections. In the non-instrumented decompressive spinal surgery with no symptoms, no post-op investigation is required. Now for patients with instrumented hardware, routinely X-rays are done at 6 weeks, 3 months, 6 months, and 12 months after surgery. And if need be, CT and MR may be done depending on the symptoms of the patient. Long segment instrumented fusions for spinal deformity correction. They are followed up for 2 years or more. Any new kind of pain or neurologic deficit immediately after surgery must be addressed. Urgent imaging may be required in these patients. So complications can occur throughout the post-op course. These may be early or late. Patients come with persistent pain or recurrent pain or a new type of pain. So early complications are wrong level of surgery. So one should be careful numbering the vertebra. Hardware misplacement, one should look for position of the hardware. Hardware loosening, look for loosencies around the screws. Epidural hematoma, particularly for patients coming with cauda equina syndrome or any kind of collection in the extrathecal spaces. Infection can occur in the early post-op period within the first 7 days. Texilloma are because of retained foreign body. These we have seen sometimes and can happen inadvertently. Late complications are recurrent disc fibrosis. These we have been reporting, and one should be able to separate these two: radiculitis, sterile arachnoiditis, fusion failure, which are seen in the form of breakage or pseudoarthrosis. Subsidence is going in of the disc spaces within the vertebra. Progressive degeneration is a progressive process we see with all degenerative spines. Others are arachnoiditis, radiculitis, metallosis. Then again, coming on to this adjacent segment disease and proximal junctional kyphosis, which we'll be going through subsequently. Immediately after the surgery, there is considerable overlap between the post-op spine and surgical changes. So one should be ideally doing a scan only after 6 weeks post-surgery. There may be paraspinal soft tissue and facet joint enhancement, increased T2 signal enhancement within the disc space extending to the posterior annulus at the site of curettage, decrease in disc height compared with pre-operative images, thin linear disc enhancement paralleling the end plates. There can be sometimes be nerve root entrapment, enhancement, ipsilateral to the site of discectomy. This is a normal post-surgical finding in the initial 3 to 6 months of surgery. Here in this patient comes with cauda equina syndrome. We see there is this large collection. This is a seroma. Sometimes there can be a large collection here. Sometimes it can be because of a hematoma. So here we are able to see hyperintense signal on T1 weighted images. There is push of the fecal sac towards the right side. This may have to be relieved if there is significant cauda equina syndrome. This is another entity where on these patients they come with severe headache immediately after surgery, and this is because of intracranial hypertension, often seen as slit ventricles, and these should be cannulated. Sometimes they spontaneously get closed. Spondylodiscitis can be occurring in the initial post-op spine. If it's large, may have to be drained. Hardware position, it is important to see. Here we see there's engagement of the right screw within the right lateral recess. The left is in position, but it's along the cortex. It should have been a little more laterally placed. Tip should be within the anterior bone margins. The rate of nerve root irritation, if it pierces the anterior cortex, is to the extent of 1%. So there should be ideal position of the screws. We should try to look at the tips. Now, this is the ideal position of the screw within the pedicle. There should be 2 millimeter medially and 2 millimeter laterally at least around the screw. But sometimes if it goes along the cortex, which would mean there is some degree of encroachment further on within the lateral spaces, further within the spinal canal towards the left side, and here almost occluding the left half of the spinal canal. So there are different grades of it. These should be addressed and reported in your reports. We just saw these. So the screw tip is within the anterior cortex. Here it has pierced the anterior cortex. Sometimes it can be irritating the lumbar nerves. Retroperitoneal hematoma as a result of vascular injury has been reported. Rectal perforations also have been reported. So one should try to follow up these clues and look at their positions through the pedicles. There are certain criteria for solid fusion of the disc spaces. Ideally, there should be no motion of the disc spaces, but up to less than 3 degrees of intersegment position change in lateral or extension positions is accepted. There shouldn't be any lucency around the implant, which would mean loosening. It should not be displaced anteriorly or posteriorly. There should be a middle position on the axial cuts. No fracture of the instrument, bone graft, or vertebra should be seen. It should generally calcify after 9 months post-surgery. It starts to show up after 6 months after the post-op spine. Now, why does implant loosening occur? Implant loosening occurs as a result of micromotion. It can also be due to infection, or it can be as a result of reaction to the polyethylene or metal. Now, osteolysis just at the tip of hardware, it is most likely to be because of mechanical loosening or micromotion. If it is diffuse, one should suspect osteolysis because of infection. Patient should be investigated with lab parameters and nucleotide imaging if need be. Certain recombinant human P2 type may result in inflammatory standing of the soft tissues and abnormal enhancement. There may be temporary osteolysis and thus mimic infection, so one should look into the history of these patients. Hardware migration, one should be looking into the position of the screws. Here, like we see, it has inclining upwards towards the superior end plate margin, and there is a fracture of the anterosuperior margin. But here, there is no fusion of the interbody disc spacer, unlike the above two levels. Besides, there is progressive degeneration at the end plate margin with further reduction in disc height. This patient again went in for surgery. There was disc spacer put in and extended. Posterior spinal fixation was done till the level of S1. Now, what is adjacent segment disease? It is a radiographic degeneration at level adjacent to prior fusion, which results in new neurological sequelae. Prior surgery increases the intersegmental motion and stress at levels adjacent to the fusion. So that is why these are vulnerable sites and may lead to degeneration of discs. The estimated level incidence of new symptomatic adjacent segment diseases to the extent of 2.9% per year following fusion and is seen in about 25% of patients at 10 years. So these are the most vulnerable sites of maximum motion after instrumentation. This forms like a fulcrum or a lever arm, and here is the maximum motion. So that is why we see here nice fusion and alignment of the vertebra and the disc spaces, good integration with the marrow here we see here. But here there is this disc with some degree of epithesis. So this patient was having symptoms because of this moderate to severe canal stenosis at this level. This patient had to undergo repeat surgery with a disc spacer there and posterior spinal fixation further extended to the level of S1. Then again here, there is this disc causing moderate to severe canal stenosis. This patient underwent 2-level spinal fusion from L4 to S1. But 3 years after surgery came with worsening pain in back and leg. So we see this large exclusion here causing severe canal stenosis at this level. There is some degree of listhesis of L3 or L4. Further on, discectomy was done and extension of the fusion was done to L3 and L4 vertebra as well. This is another patient, 66-year-old male, L3 to L5 spinal fusion done 10 years ago. Now comes with severe pain and listhesis here, markedly reduced disc height here, and also at L5S1. And there is some degree of listhesis, which is seen nicely on MRI. Severe canal stenosis at this level at L2. So this patient underwent extended revision posterior spinal fixation with osteotomy of L3 vertebra. We see here extended instrumentation from T10 to the pelvis. The patient subsequently showed improvement, went to rehabilitation and is walking with aids. I thank Dr. Jacob from our hospital for these slides. Now coming on to proximal junctional disease. Following a long segment fusion, the vertebra above the level of the fusion might develop a compression fracture, most with osteopenic bones. It differs from ASD. ASD is particularly to do with the discs, and proximal junctional kyphosis is basically collapse or fracture of the vertebra above the prosthesis. Frequencies to the extent of 20 to 30% of cases, particularly in osteopenic bones. Here we see there is marked angular kyphosis just at the level of the proximal prosthesis. So these are two terminologies, PJK and proximal junctional failure. Proximal junctional failure is a severe form, and they mostly need revision. They can land up in paraplegia. These have to be addressed immediately. Proximal junctional kyphosis is a milder form. They may or may not be symptomatic. This is a diagrammatic representation. We see good alignment of the vertebra and posterior spinal fixation, but then because of all the pressure and stress here at this level, there is compression fracture and angular kyphosis at this level. This is particularly seen with extended posterior spinal fixations and markedly orthopedic forms. Other things are because of some degree of muscle asthenia, post-surgical. Here is a case with severe compression fracture of L2 vertebra with angular kyphosis. Here, marked compression we see well on CT. We see also displacement of the upper screws above pointing upwards to the vertebra. Further on, this patient had to undergo corrective osteotomy, and with good correction post-op spine, we see good alignment of the vertebra here. So this is the osteotomy side with fixator. There's also compression fracture of L4 vertebra. Recurrent disc disease, we all know. This is often a complication following surgery and generally seen 6 months. So recurrent disc herniations defined clinically as recurrence after a 6-month pain-free post-operative period, varies between 3 to 18% post-lumbar discectomy in retrospective studies. So here we see there is good alignment of the vertebra. This nice displacers and integration of the interbody displacers. But then on MR, we see this large disc which is continuous with the disc here, with extrusion and cranial migration causing severe compression of the fecal sac. This differs from scar because it is so well defined and we know it is continuous with the disc. So this patient underwent spinal fixation and discectomy and was doing well. Here we see this patient comes with pain, but then here at this level, it looks much like the disc, but on giving contrast, there's an enhancement. So this is T2 also, there is appears to be some kind of a fissuring. But then after giving contrast, there is this irregular enhancement around the fecal sac. And this was seen 2 years later, showing enhancement at L4-5. So how do we differentiate recurrent disc from post-op scar tissue? Recurrent disc displaces and compresses the adjacent structure. It is well circumscribed, as we see here. A peripheral nil enhancement that's contiguous with the parent disc. Post-op scar tissue causes a retraction of the adjacent structures. They are generally ill-defined, as we see here. Homogeneous enhancement is seen with the scar tissue. It is not contiguous with the parent disc. So one needs to differentiate these two. Other causes of low back ache post-surgery, severe pain, is arachnoiditis, radiculitis. We see good position of the chorda equina dispersed around the filum terminal. As we go down in the lumbar canal, we see that it spreads out and further it is so well spread out in the lowermost L5S1 region. But here we see there is clumping and thickening of the nerve roots. Further on here again, they are quite mass-like. We don't see these kind of dispersion of the nerve roots. Here it is almost adherent to the fecal sac and barely we get to see the nerve. This is what is called as the empty sac sign. So these all should be looked into and addressed in our reports. Metallosis used to be common with the older forms of metallic prosthesis. And this is taken off from the literature. What we see here is basically there is some depletion of the metallic particles. So this prosthesis looks a little faded as compared to the rest of the prosthesis. Besides, there is this big granuloma formation pushing the leukocyte towards the right side. So one needs to be aware of this. Through my practice, I haven't come across one, but yes, I have seen some older presentations. One should be careful of this. Degenerative disc disease is generally a progressive process. We might do a surgery, but there is some degree of progression even otherwise. 2 to 3 columns are a must for spinal column stability. Often in the post-op spine, degeneration starts to occur soon after surgery. Instability occurs in the form of spondylolisthesis. So one should look for vertical alignment. Any spondylolisthesis should be addressed. Besides, the ends of the prosthesis should be particularly focused at, because most brunt of movement is at these levels. Here we see this extruded disc. We just saw this a little while ago. Marked compression of the thecal sac. So, what does the surgeon want to know? CT scan is done pre-operative to look at the size of the pellicles, if they are hypoplastic or they are of the dysmorphic anatomy, if there's adequate space for posterior spinal fixation or the screw fixation. CT scan to look for screw lesion, if there's any lucency around the screws, if there's any necessity of putting grafts around the screws to prevent motion of the screws. Is it encroaching within the spinal canal, which may be a cause of nerve irritation, and this have to be addressed. CT scan to look for non-linear. Is there a fusion of the interbody spaces? Is there a need to incorporate more bone graft within the disc spacer? Then adjacent segment disease, as I said, always look proximal and distal to the prosthesis. These are the areas of maximum motion and are the most vulnerable sites. So adjacent segment disease is to do with the disc, and proximal junctional kyphosis is to do with the vertebra. MRI is to look for patency of the central canal mode. If it is adequate, if there is, look at the nerve roots, if immediate post-op period, if there is sporadic pinna syndrome, look for any collections. So that are some of the pertinent things that one should look into. So these are some of my references. So this is our Tantalk Saint Hospital where I work. Thank you very much for your attention.
Okay, thank you, Dr. Rupakdita, for your very comprehensive presentation. And next, we want to welcome Dr. Srinath Bopana from Kamini Hospital, Hyderabad, India, and also from Senior Consultant Radiologist Sakrawat Hospital, Bangalore, India, with the title of the presentation, CT Imaging of Orthopedic Implants. Dr. Bopana, time is yours, please.
Hello everyone, I'm Dr. Srinath. I'm going to talk on dynamic ultrasound of snapping syndromes today. So what is a snapping syndrome? It's a sudden impingement of one anatomical structure against a neighboring one with a subsequent jerky movement that may be associated with pain and crepitation or an audible pop. So it is reported in various regions of the body, usually in the close vicinity of a joint. You need to have movement to perform a snapping. So it occurs only in the vicinity of joints. It can be because of various extra or intra-articular causes. It can range from tumors to anatomical abnormalities, even loose bodies within the joint, a previous surgery or a trauma with an implant, and articular degeneration and inflammatory processes. Sometimes they are associated with other complaints. So how do they actually present? So diagnosis is predominantly by history and physical examination. There can be an associated audible snap. Sometimes the patients complain of pain. Also sometimes because a neural structure is also involved in these ones. They can also be neurological alterations within that area. There are certain specific maneuvers to perform this snapping syndromes. Imaging is utilized for confirming and documenting the anatomical structures or lesions associated with this snap, thus guiding a possible treatment for these cases. We will start with snapping hip syndrome, which is the most common one that can occur. Usually young adults, commonly athletes and dancers, complain of snapping hip syndrome. This could be because of extra or intra-articular causes. We'll look at various types of snapping hip syndrome. Let us look at, you have extra-articular and intra-articular varieties. In the extra-articular, again, you have two varieties. One is an external, the other one is an internal. In extra-articular external variety, what will happen is there can be a thickened posterior aspect of the iliotibial band or the anterior gluteus maximus muscle, which snap over the greater trochanter when the hip is extended from a flexed position. So how do we perform a diagnostic test? With passive flexion of an extended hip, it can elicit a palpable or an audible snap with pain over the greater trochanteric region. Coming to the extra-articular and internal variety, where the iliopsoas tendon snaps over the anterior hip capsule or ilopectineal ligaments. So for this, what you have to do is passive extension, internal rotation, and adduction of a flexed, externally rotated and abducted hip. So simple terms, you can keep the patient in frog-leg position and bring it back to neutral position. That is when you can actually elicit an internal hip snap. Coming to the intra-articular causes for snapping hip syndrome, you can either have loose bodies, torn acetabular labrum, recurrent subluxation, habitual hip dislocation in children, or synovial chondromatosis. And how do we perform the diagnostic test? It all depends on the cause of the intra-articular hip syndrome. The ultrasound technique for extra-articular causes. In extrinsic variety, place the patient in the lateral decubitus position on the contralateral side and keep the hip in flexed position. Place your transducer in a transverse axis over the greater trochanter. What you're going to see is the echogenic iliotibial band over here sitting on the greater trochanter, and also the gluteus maximus muscle, which is hypoechoic, posterior to the greater trochanter. These are the structures that you're going to see when you place your transducer on the greater trochanter in an axial location, in an axial plane. Once that is done, perform the maneuver, right? Passively flexing the hip and extending it back. So this patient is a 30-year-old male patient who's got a visible hip snap and complaining of sudden jerky movement as well as some pain in that region. So on flexion and extension, you can see on flexion, the gluteus maximus muscle is completely snapped over the greater trochanter. And on extension, it is snapping back posteriorly over the greater trochanter. If you look at a dynamic maneuver there, that's the area of the hip snap over the greater trochanter. This is a classical case of extrinsic hip snap. But on ultrasound, what you're going to see is the gluteus maximus muscle is going over the greater trochanter on flexion and snapping back on extension, causing the jerky movement and pain for this patient. This is a classical case of extrinsic hip snap. There can be other reason why it can occur. The one thing is gluteus maximus. The other one is because of thickening of the iliotibial band. Here you're seeing that iliotibial band is thickened and fusiform in appearance. And this is snapping over the greater trochanter. This patient is a yoga instructor who's performing difficult yogas and started complaining of pain in that region. Coming to the intrinsic hip snap, what you see is the iliopsoas muscle and tendon. They can go over the ilopectineal ligaments and rub over that whenever you perform a frog leg position and bring it back again to normal position. So if you look at a dynamic ultrasound here, that's the iliopsoas, and here's the ilopectineal. You can see a small pop over there when we try to bring the patient back to neutral position from a frog leg position. That's where you can actually visualize a small pop. There, yeah. And it can also occur in a different variety where the muscle of iliopsoas can actually get behind the iliopsoas tendon and snap backwards. So that's a muscle which is going under the tendon and snapping back on neutral position. So these are the two causes why you get intrinsic hip snap. One is the iliopsoas tendon snapping over the ilopectineal ligaments. The other one is iliopsoas muscle itself going behind the iliopsoas tendon and causing a snapping sensation. This is another patient where the snap is very much evident. That's the iliopsoas tendon. And on a movement of the hip, what you're seeing there is significant snapping of the tendon. So you can see that certain jerky movement of the tendon over the iliopectineal ligaments. Then the other thing is, in case of habitual dislocation of hip, this child, look at the clinical video, the child herself can actually perform a snap of the hip there. You can also listen to that noise there. And an ultrasound from the posterior aspect, you can see the hip is actually coming out and snapping backwards whenever the child is performing the same movement. You can time the snap with the ultrasound video as well. That's the hip which is coming out and jumping back inside from into the acetabular. This is a habitual dislocation of the hip joint. Then coming to peroneal tendon snapping. This is uncommon, but it is not very rare. The incidence is 0.3 to 0.5% in cases of ankle trauma. Whenever there is an inversion and dorsiflexion injury of the foot, the ankle with simultaneous contraction of the peroneal tendons, that is when the peroneal tendons actually jump out of the peroneal groove, stripping off the peroneal retinaculum as well. This can happen with common twisting injuries of ankle. These peroneal tendons, once they are free from the peroneal groove, they can actually subluxate over the fibular tip. There are two varieties again. You have a typical subluxation and an interseat subluxation. Typical subluxation, what can happen is one or both of the peroneal tendons, they subluxate anteriorly over the lateral malleolus with the tear of peroneal retinaculum. This is a typical subluxation. But what is an intersheath subluxation is the peroneal tendons remain within the peroneal groove with an intact peroneal retinaculum. The peroneal retinaculum can get stretched sometimes and allow the peroneal tendons to snap against each other. In this, again, there is two varieties. A type A, where the peroneus brevis and longus tendon, they interchange their positions. They switch their positions on dorsiflexion and eversion of the foot. In type B, what you have is there is a peroneus brevis vertical split tear, and the peroneus longus tendon subluxates through the longitudinal tear of the brevis tendon, preventing it from healing as well as causing significant amount of pain to the patient. So what is the ultrasound technique? Place your transducer directly over the peroneal groove. You can use a 12 MHz transducer for this one. Either you can perform while the patient keeps the foot away from the couch, or you can do the patient to the contralateral side and also do it from the lateral aspect. So the dynamic maneuver that you do is foot is dorsiflexed and everted both passively and actively from a neutral position to see if there is any dynamic subluxation of the peroneal tendons. So here is a typical peroneal tendon snapping. What can happen here is this is a 33-year-old male patient who has got a trekking injury. And on the contralateral side, on the left side, you can see the longus and the brevis tendons, which are normally situated. And on the contralateral side, the affected right foot, you're seeing the peroneus brevis tendon is already dislocated anterior to the fibula, and there is no peroneal retinaculum. And the longus is seen posterior to the fibula. On dorsiflexion and eversion, you can actually see the peroneus longus is also jumping over the fibular tip, leaving a fluid-filled space in that peroneal groove. So this is a classical case of classical case of typical subluxation of the peroneal tendons. That's a video. Here is the brevis tendon. That's the longest tendon. On dorsiflexion eversion, you can actually see the dorsal, the peroneal longest tendon is also going anterior to the fibular tip, leaving a fluid-filled space over there, and the peroneal retinaculum is completely torn. A classical case of typical peroneal tendon subluxation. When you look at the other variety, that is the intersheath subluxation of the peroneal tendons. This is the type B variety where the peroneus brevis is already torn into two vertical splits, and the longest is seen between these two. And on dorsiflexion and eversion, you can actually see there is anti-clockwise, there is a clockwise movement of the longest tendon between the peroneus brevis split ends. So this causes significant pain to these patients. There's a 40-year-old female patient who was performing lots of aerobics and Pilates and ultimately complained of significant pain in the peroneal region. If you look at the dynamic video, this is one part of the peroneus brevis. This is the other split end of the peroneus brevis. And the longest is seen in between these two vertically torn ends. And on dorsiflexion and eversion, you can actually see the peroneus longus tendon goes in between these two split ends and moves around it, preventing it from healing as well as causing significant pain. That's a intersheath subluxation or atypical subluxation of the peroneal tendons. Sometimes you can just have the normal tendons which are interchanging in their position and causing some snapping sensation to the patient within the sheath. That is a type A variety of intersheath subluxation of peroneal tendons. We'll move on to the upper limb, and the commonest one here is a snapping scapular syndrome, where you can actually palpate a crepitus in the scapulothoracic region whenever the patient performs an abduction. So it is a largely under-recognized problem. Again, it can be very common in young and active population. There is a disruption of smooth gliding movement of the scapula over the thorax due to soft tissue, muscle, skeletal, or bursal pathology within the scapulothoracic space. There can be various causes for this, ranging from bony pathologies like an osteochondroma or a prominent Leschker's tubercle, sometimes even a rib fracture. But soft tissue pathologies are what we're looking at right now. The commonest one is bursitis. Then there can be muscle weakness, atrophy, and anatomical variations. And sometimes even an elastofibroma or a chondrosarcoma can cause mechanical disruption of the smooth gliding movement of the scapula. So, coming to the scapulothoracic bursitis, there can be various bursae around the scapulothoracic region. The commonest that we look at are the infraserratus bursa and the subscapular bursa. Here, if you place your transducer along the medial aspect of the scapula, first you can actually palpate where the crepitus is coming from and place your transducer axially over the scapulothoracic region. Always include the medial end of the scapula, and the rest of the transducer should cover the rib cage and perform the particular maneuver. The patient himself can actually tell you where exactly it is occurring and in what movement he can actually reproduce the same snapping sensation. So also sometimes you need to compress over the superior angle of the scapula to elicit the snapping better or the crepitus better. So here is a 20-year-old female patient who's got a painful snap of the right shoulder, and what you can see by placing the transducer over the scapulothoracic region. This is the scapular margin, and here is the rib cage, and these are the muscles around that region, being the rhomboids and other things, and that's the space between the scapula and the rib cage. So on a particular moment, like in this patient, it was only abduction of the shoulder. We could see a small bursa popping out from the scapulothoracic space and getting back on, getting inside the rib, between the space, scapulothoracic space on bringing the shoulder into neutral position. So this is causing significant pain to the patient. If you look at a dynamic video on abduction and adduction of the shoulder, that's a small bursa which is popping out and causing a snapping sensation there. So that's a scapula. Here is a rib cage and a popping out bursa from between these. So other varieties of shoulder snapping would include a subacromial or a subcoracoid bursal snapping under the acromion or even the coracoid process. Here is a coracoid subcoracoid bursa, which is restricting the movement of the shoulder. Or an external rotation, you see the bursa is actually collapsed, and as you bring it to neutral, you can see mild buckling of the bursa there, and on internal rotation, the bursa is actually really buckled up over there and suddenly disappears under the coracoid process, causing a audible and a visible snap to this patient. So if you look at here, that's a bursa which is suddenly disappearing, and which is actually causing a clicking noise to the patient, and also simple snap in that region. Yeah. So coming down from the shoulder, we'll go to the elbow. Elbow snap is the commonest one what people look at in clinical practice, be it an ulnar nerve snapping or tricep snapping. Ulnar nerve snapping, where the ulnar nerve dislocates from the cubital tunnel over the medial epicondyle with elbow flexion. Whenever you feel you actually move your elbow, sometimes the ulnar nerve just jumps out from the cubital tunnel. Either it is because of the deficiency of arcuate ligament, or there is no retinaculum over there, which can cause ulnar nerve snapping. It can be seen in 16% of healthy subjects. It can also be associated with something called as a snapping tricep syndrome, where the medial head of the triceps muscle also snaps over the medial epicondyle while you perform an elbow flexion. So it can present as a medial elbow pain, snapping, and also as ulnar neuropathy, because there is a friction neuritis coming in the ulnar nerve when it rubs over the medial epicondyle. Ultrasound technique, again, just place your transducer over the cubital tunnel. How do you do that is, take the olecranon process and the medial epicondyle, place your transducer over that. You're going to visualize the ulnar nerve in the cubital tunnel. On flexion of the elbow, In case of ulnar nerve snapping, what you see is the ulnar nerve gets anterior to the medial epicondyle and lies superficial to the common flexor tendon. Here is the medial head of the triceps, which is coming up till here, but not really crossing the medial epicondyle. So this is an isolated ulnar nerve snapping happening on flexion of the elbow, with the ulnar nerve jumping out of the cubital tunnel and seen anterior to the common flexor tendon. So that's a dynamic evaluation of the ulnar nerve here. And here is the medial epicondyle. That's the common flexor tendon. On flexion of the elbow, you see the ulnar nerve actually is going over the medial epicondyle and rubbing over the bony surface. But if you look at the medial head of the triceps, is not really crossing the medial epicondyle there. That's an isolated ulnar nerve snap, and it can present with tingling and numbness over the ulnar aspect of the hand and fourth and fifth digits. Sometimes it can be associated with the triceps snap as well, where you can see the ulnar nerve here situated posterior to the medial epicondyle. On flexion, you see the ulnar nerve along with the medial head of the triceps jumping out of the cubital tunnel and seen superficial to the common flexor tendon as well as anterior to the medial epicondyle. So if you perform the same maneuver as flexing the elbow by clipping your transducer over the olecranon process and your medial epicondyle, that's when you can actually see the ulnar nerve along with the medial head of the triceps snapping over the medial epicondyle. This case has actually been this patient is suffering from ulnar neuropathy, genius of ulnar neuropathy. So repositioning of the nerve is the option, because anyway the medial head of the triceps would always push the ulnar nerve out of the cubital tunnel on flexion of the elbow. Coming down from the elbow, we have the hand. In the hand, the extensor tendon snapping of the hand is quite a common thing. If you look at the extensor tendon over here, it is kept in position by sagittal bands in this extensor retinaculum. These are the ones which form a girdle around the extensor tendon and keep the tendon intact and in position over the metacarpophalangeal joint. So what is the cause of this? One is a direct blow or a sudden forced flexion of the joint. It can actually cause tear of the sagittal bands, and ultimately the tendon slips onto the ulnar aspect of the metacarpal head. Commonly, the middle finger is involved, and somehow it has a propensity towards ulnar aspect. So the tendon usually dislocates onto the ulnar side of the metacarpal head. It is also quite common in boxers, so it is called as a boxer's knuckle. Place your transducer directly over the metacarpophalangeal joint. What you're going to see is here is the extensor tendon along with two sagittal bands, the bands over here, which are running from either side of the extensor tendon and keeping it in place whenever you flex your finger. So the dynamic ultrasound is flexion and extension of the fingers and see what is happening with the extensor tendon at the metacarpophalangeal level. So here is a patient where the extensor tendon is in place in neutral position or extended position of the finger, but the sagittal bands are not visualized on either sides. There is a tear of the sagittal bands. This is the ulnar aspect and here is the radial aspect. And this is the extensor tendon. On flexion of the extensor tendon, you see that the tendon is actually dislocated towards the ulnar aspect of the metacarpal head. And because of the deficiency of the sagittal band, it happens easily. So that's a dynamic video. And you see the extensor tendon, that's a slow motion. You can see the extensor tendon is slowly heading onto the ulnar aspect of the third metacarpal head. So on dynamic ultrasound, you're seeing that the tendon suddenly jerks over the metacarpal head onto the ulnar aspect because there is a deficiency of the sagittal band over here. It can happen to normal people. They don't even recognize that there was an injury before. So once that is done, we'll go to the finger level where another common condition called as a trigger finger. What can happen in a trigger finger is the A1 pulley, which is an annular structure surrounding the flexor sheath of the flexor tendon, can be very much thickened and prevent the normal movement of the common flexor tendon. It can also be associated with flexor tenosynovitis. A stenosing flexor tenosynovitis coupled with A1 pulley thickening can usually cause snapping or triggering of the finger. It is quite common in the thumb region. So what do you see? You place your transducer directly over the flexor tendon at the A1 pulley level, that's at the first MCP joint. You're going to see the flexor tendon like this, and there is a thin band keeping it in position. That thin band there is called as the A1 pulley. It is a submillimetric structure. So in case of trigger finger, what can happen is there can be significant tenosynovitis of the flexor tendon along with thickening of the A1 pulley. You can see the A1 pulley here is really thickened and preventing the movement of the flexor tendon whenever they perform flexion and extension of the finger. So you got to use lots of gel because the footprint of the transducer, you cannot really place it over the finger while you perform a flexion. So use a huge gel pad over there like this and try to ask the patient to do the flexion extension of the finger. There, that's A1 pulley, and you can see the jerky movement of the flexor tendon just coming from under the A1 pulley on flexion extension of the digit. That's a snapping sensation, snapping or popping of the trigger finger. This is a thumb which is showing the trigger finger. So to conclude, snapping syndromes are a group of challenging clinical conditions which are not routinely encountered in day-to-day practice. So the knowledge of these conditions is very essential and important for a precise diagnosis and guiding the management. And also, you should have a sound knowledge of the relevant anatomy, the ultrasound positioning, technique, and the appropriate maneuvers at different locations for a dynamic ultrasound to essentially make an accurate diagnosis for these patients. And thank you one and all for the patient hearing. So with this, I conclude my presentation.
Thank you, Dr. Bopana, for your very informative presentation. And now, for the last speaker of this session, we would like to invite Professor John George from the University of Malaya, Malaysia, to give a lecture about his past experience on PRP, titled PRP Personal Perspective, Indication, Preparation, Technique, and 2-year outcomes. The Professor John George, time is yours.
Greetings from Malaysia. Thank you, Dr. Paulos and the AMS committee for this Congress for inviting me to share my experience on the use of PRP in musculoskeletal injuries. I have been using PRP, particularly in the last 2 years, and both at the National Sports Council and in the private center. And I would like to share the outcomes of the use of PRP, as well as some of the indications and the types and preparation of PRP. So my email is given here in case you want to correspond with me. So the learning outcomes of this talk will be what is PRP, how does it work, how is PRP prepared, important aspects of administration of these injectables to ensure best outcomes, outcomes of above injections in the last 2 years based on VAS scores and also functional scores and some comparison with literature on this outcomes as well. So in terms of biologicals, platelet-rich plasma is one of the injectables that is used for regeneration and healing of joint injury. In my own experience, here are some of the indications that I've been using. In tennis elbow, it has excellent results. Also in painful insertional tendinosis and partial tears, such as jumper's knee, infrapatellar tendon tendinosis, Achilles insertional tendinosis and tears, common origin of hamstring injury, tendinosis and tears, pure tendinosis without bursitis or tenosynovitis. I've used it in pes anserinatus, also in D. quervens tendinosis, where the tenosynovitis is not prominent. And then in supraspinatus tendinosis, with or without partial tears, and muscle tears grade 2B, usually in the hamstring, MCL, LCL partial tears grade 2B, meniscocapsular injury, peripheral meniscal tears, which can be visualized on ultrasound, particularly in the medial meniscus, in the lower back, in the quadratus lumborum and erector spinae, usually grade 2B tears, partial tears of ATFL and CFL or ankle deltoid ligaments, intrasubstance tendon tears also of the posterior tibial tendon, spring ligament, peroneus longus tears, and also of the peroneal retinaculum. I do use it also for injecting tears of the patellar retinaculum. So another indication that I've been recently using is for grade 2 or 3 OA changes of the joints based on recent literature, which I'll share. So platelets are basically cytoplasmic fragments of megakaryocytes, and the important thing is that they contain more than 30 bioactive proteins, many of which have a fundamental role in hemostasis or tissue healing. And the kits that we get, the PRP kits that we get, are basically have a gel to separate white blood cells and red blood cells. So let's look at some of these platelet growth factors and what they do. As you can see, for instance, the TGF alpha beta can be used for collagen synthesis and collagenase secretion, which is for tendon regeneration. And you can see also vascular endothelial growth factors for angiogenesis and vessel permeability. And of course, mesenchymal cell differentiation. So basically, there is like a stem cell effect that allows for the mitogenic effect of these mesenchymal cells. In terms of platelet concentration, one may ask, is the very high concentrations of platelet, like 4 or 5 times normal, needed? Literature shows, as you can see from these articles that I've sourced, that 1.5 to 2.5 times normal is sufficient. And in general, eliminating neutrophils is considered better than leukocyte-rich. So the types of PRP, therefore, are pure platelet-rich plasma or leukocyte-poor. So basically, when you talk about platelet-rich plasma, we are talking about leukocyte-poor. And then you have leukocyte-rich PRP. And then these two PRPs are low-density fibrin network. And then you have the pure platelet-rich fibrin, which is the leukocyte-poor platelet-rich fibrin preparations, and also the leukocyte-rich fibrin products as well. So in the preparation that most of us use in the kits, basically if you're using first or just a single centrifugation, usually these are around 3,200 RPM for around 5 to 7 minutes. And you use actual kit with a gel polymer, and you will get the platelets in the plasma. And this is what I mentioned that I use. And the purity of the platelet separation depends on the type of kit. So some of the better kits are able to have a much purer platelet concentration without the mix of neutrophils and red blood cells. Now, if you're using a second centrifugation, then there will be the much more concentrated platelets mixed with some neutrophils as well. So just to show you, this is the product that I use. I do not mention the commercial name, but you can see that red blood cells are removed at 99.7%. The white blood cells, 96.7%, particularly the pro-inflammatory granulocytes, which are thought to have an antagonistic effect. This volume that we need per kit or per tube is 10 mils of blood, from which we can generate 5 to 6 mils if you do a correct centrifugation technique. And the platelet concentration that I obtain is around 1.6 to 2 times. Now, as mentioned, there are some proponents for leukocyte poor PRP and others for leukocyte-rich PRP. The proponents for the leukocyte-rich PRP say that leukocytes have cytokines and enzymes important to the healing process, can prevent infection. But the proponents of leukocyte-poor PRP indicate that these pro-inflammatory cytokines and enzymes such as matrix metalloproteinases can have antagonistic effect. So if we go through the literature then to check, you can see that there are a lot more studies and systematic reviews that suggest that leukocyte-poor PRP has a better and significant effect than leukocyte-rich PRP. And so this is what I tend to recommend and use. Now, in giving a PRP injection, it's important to explain to the patient. I have a patient information sheet prior to coming for the procedure on what they need to do before, during, and after. I stop anticoagulants just a day or two before and started a day or two after the procedure. Usually, as long as one can stop the bleeding site, like if it's a superficial tendon, then you don't have any issues, or the patient has no reason to continue bleeding due to any specific blood disorders, then usually it's quite safe. We stop all NSAIDs for a few days before and a week after as well. That can also have an antagonistic effect. We sign a consent form. And post-PRP, the first few days, no major activity or stretching. If the pain is intolerable or really painful, I actually advocate using icing for 5 minutes or so, just to numb the pain, which is not able to be controlled with usually Panadol. So icing I've not found that icing has affected the efficacy of the PRP. Rehabilitation should start as a graded rehabilitation, usually from week 2 to week 6. So my personal experience with tendinosis, I've mentioned all the indications earlier for which I use PRP. And in terms of outcomes, I have found that we will obtain after a single injection a 70 to 100% reduction in pain in those conditions that I mentioned earlier. Sometimes persisting pain is due to unmasking of other causes of pain, not due to the original condition that I injected PRP. This may be due to some bursitis, which might need steroids. And also, if there's only 50% response or more, then a second PRP injection can be considered. So I don't normally say that you need 2 or 3 as a set of PRP. I will look at the initial injection effectiveness. Now, in recent last 27 patients that I injected here, the VAS scores, you can see mean scores of 8 pre-injection and mean scores of around 2 after the injection. Most patients are very comfortable at this point with a score of 1 or 2. As you can see, some have no pain at all and some don't recover, but these are the ones that may have other conditions as well, so need to be evaluated. But generally, the VAS scores reduce significantly and patients just carry on with rehab. It's rare that I have to inject a second time. Functional scores also, depending on the type of functional score, increase or decrease significantly. Now, in terms of other literature showing the clinical and functional outcome, here's one of a rotator cuff tendinopathy injected with platelet-rich plasma, and you can see the significant change, p-values which are significant between pre-injection and the 12th week. So you can see the VAS scores, 7.4, 1.9, SPAD scores, 73 to 18, and mean constant Merle scores from 39 to 86. So all showing excellent outcomes with pain reduction and increase in function. So when does PRP not work? Well, when you use kits that don't have a good gel polymer that to separate the platelets, or you get too little PRP, like 2 or 3 mils of PRP, and it's not enough to cover the region affected. I tend to love to use much more PRP, and sometimes even give 2 kits worth of volume if needed. Ultrasound guidance was not accurate because you did not use high resolution ultrasound, not optimizing the image. And also I use ultrasound sensitive needles so that the needle tip must be seen clearly. So I know that I'm injecting into the middle and just into the region of abnormality. Now, in terms of OA, which I mentioned, can PRP regenerate cartilage or does it just stabilize? So we need to look at recent papers that talk about regeneration. Many of them are in vitro studies in animals. And there are papers that talk about how does PRP help, and they talk about the major growth factors in OA regeneration of cartilage are these growth factors which are mentioned here, several of them which I mentioned earlier, and also reducing the effect of interleukin-1 beta and tumor necrosis alpha. So when PRP is injected, basically within the first 10 minutes, there's a release of 70% of the growth factors. And these are the ones that stimulate the chondrocyte chondrogenic proliferation. So the role of PRP in OA is also not just cartilage, but in other factors such as synovial fluid homeostasis, modulating inflammation in the joint, cell migration, and cell recovery. Now, Zhu, Yin, and Zhang have this animal study in which they have a control at 6 and 12 weeks, leukocyte-rich PRP and pure PRP at 6 to 12 weeks. And if we look at their results, we can see that in the leukocyte poor, after 6 weeks at looking surgically, where they look at macroscopic observation, the full thickness cartilage defect sites appeared glossy white, mostly well-integrated, regenerated tissue in the pure PRP group, but the surface was not as smooth as normal articular surface. And the leukocyte-rich group was filled with regenerated bone with tissue halfway covered with whitish cartilage tissue. And in the control group, of course, that remains with the concave defect at 6 weeks. Now, at 12 weeks, the regenerated tissues seem to be similar in the pure PRP and leukocyte-rich PRP, but the difference was the regenerated tissue looked more opaque and closer to adjacent cartilage tissue in the pure PRP group. So there's no doubt that in these studies that cartilage is regenerated, and therefore defects which are grade 3 should become grade 2 and likewise grade 2 should become grade 1 anecdotally. So there are many other studies and meta-analysis that talk about the efficacy of PRP in OA, all with positive significant improvements that are mentioned. My personal trial of PRP is in the knee is that I do not ask them to be immobile after the injection, because often if they are immobile, the PRP causes a capsular reaction and stiffness, and they complain of marked stiffness in the knee and inability to flex the knee, and they are worried about it. So I recommend that they exercise right from the beginning and keep the joint mobility. Interestingly, when we review them at 2 to 3 weeks, I can see hyperechoic substances, which I assume is the PRP visualized in the fissures of the grade 2 and 3 cartilage. This looks promising. Maybe this suggests that the PRP is integrating into the cartilage, but I've not got any biopsy proof of that. So I've come to the end of my lecture on PRP, and basically I have talked about PRP, how does it work, how is it prepared, the kits and the types of centrifugation, the basically the growth factors that are involved, the 30 or more growth factors, how it's important to administer these under ultrasound guidance with ultrasound sensitive needles, the amount of volume, the concentration of the platelets. And also I've talked of my own study and other studies where the pain scores are reduced markedly and significantly from 8 to 10 to 0 to 2, and functional scores, depending on the type of scores, doubled or decreased. So the meniscocapsular tears can be healed. As you can see here is the meniscal tears in the medial meniscus. Here there is a tear that is present peripherally pre-PRP, and it's healed post-PRP. And there's regeneration of MCL fibers that you can see here post-PRP. So thank you for your attention, and I would like to mention about this Global Penang MSK MRI and ultrasound courses that are held annually in Penang and Kuala Lumpur. Please visit our website or Google Global Penang courses, and you can see the testimonials and photos, and you will be taught how to report MRI of joints with 95% accuracy, and also do diagnostic MSK ultrasound in Kuala Lumpur, Penang. Thank you for this opportunity to share with you.
Thank you, Professor John George, for a wonderful session, which concludes our 24th annual scientific meeting of Asian Musculoskeletal Society. So now I would like to invite Dr. Paulus to close our meeting today. Dr. Paulus, please, time is yours.
Thank you, Dr. Tarika Salama. Dear colleagues, we are at the end of the first half of our combined meeting, which is the AMS Annual Scientific Meeting. The Indonesian MSK Radiology Society meeting will be held next week. And on behalf of the President of AMS, Professor Tamotsu Kamishima, and the AMS Executive Committee, we would like to offer our greatest appreciation first for the 41 speakers from AMS, the moderators, and thirdly, to the organizing committee chaired by Dr. Elisanti Dwi Martadiani. We will see each other again in the next AMS Annual Scientific Meeting in Hainan, China in September 2023. Please monitor for the exact date through our AMS website. The AMS speakers are free to attend the Indonesian Musculoskeletal Radiology Scientific Meeting, the 23rd and 24th of this September, the next weekend. However, most of the presentation will be in Indonesian with English in the PowerPoint slide. Speaker certificate will be sent next Tuesday, September the 20th, 2022. And lastly, we apologize for any inconvenience. See you in Hainan, China. Let me hand over to Dr. Elisanti for some final announcement.
Thank you, Dr. Paulus Raharjo. We have now reached the end of the AMS Annual Scientific Meeting session. Thank you for your participation. Please join us next weekend for 10th Annual Scientific Meeting of Indonesian Musculoskeletal Radiology Society. We remind you that the website will stay open until 17 October 2022, and you can access on-demand recording of the lectures until that time. We also invite you to visit our sponsor booth in the exhibition hall and e-poster exhibition. Thank you very much for your attention and see you next weekend.